Good evening, everyone. Good evening, beta. How are you all? I am Dr. Amit Gupta, your Obs Gynae faculty from MIST. We are starting this Obstetrics and Gynaecology 25 most important question, clinical and conceptual questions. In these 2.5 to 3 hours, we will squeeze Obs Gynae and we will make a juice of Obs Gynae that will be highly useful for 28th June FMG exam. Let's start this session with the pick of Dr. Juhi Sompura. Last session, All India rank 1 from MIST. Very down to earth girl, very simple girl. She scored 251 marks. And as a part of protocol, we got the opportunity to refund her 100% fee because MIST refund 100% fee for All India rank 1. So it's a proud moment to share this once again that we got this opportunity, we got this privilege to refund 100% fee to Dr. Juhi Sompura. We got the opportunity to celebrate her moments when she came to MIST after collecting her certificate from NB, and I still remember she was very well connected during the studies, was asking difficulties. 3 days back she called me and said, "Sir, I am coming to NB and MIST on such and such day." So I asked, "What will you eat, bitya? Kya khaogi?" She said, "Sir, golgappa khaungi." This sentence is very close to my heart, maybe because I also love golgappa very much. Proud parents, see the happy face. See the happy faces. मम्मी के चेहरे पे जो खुशी, पप्पा के चेहरे पे खुशी. We live for these moments, beta. We have to pass this exam with flying colors for these moments. Your lovely Vinit sir, the awesome surgery faculty, nobody in the world can teach surgery like him. उनके जैसी सर्जरी रसगुल्ला बना के पूरी दुनिया में दूसरा शायद ही कोई पढ़ा पाएगा. Your Deepa ma'am, your awesome PSM faculty, she just squeezed the PSM, although a dry subject, but tries to convert the PSM in the form of a poem. Yeah. So let's begin this session with our question number 1. It's a long question. It is in front of the screen. So I am just hiding myself so that you can read the whole question. मैं छुप जाता हूं जिससे आप पूरा क्वेश्चन पढ़ लो बेटा. All of the following statements about types of breech, pathophysiology and delivery maneuvers are true except option A, frank breech is hips flexed, knee extended, most common and surface breech type, legs delivered by Pinard. Listen and read each and every word carefully, beta. Shoulders delivered by Lufsets, after coming head delivered by pipe of forceps or Burn Marshall. Option B, complete breech is hips and knee flexed, both flexed, more common in multipara. Option number C, footling breech, where the feet come first, most dangerous breech due to maximum risk of cord prolapse. So we plan cesarean section to deliver this breech. Option D, in all breech types, after coming head delivers spontaneously by gravity. So no risk of any intracranial hemorrhage. The house is yours, beta. House is yours. Let me see. Wow! Wonderful. Everyone answer option D. Everyone answer option D. Very good. Wonderful, beta. Let's see how. Let us see how is it like this. Yeah. Let us discuss complete breech where thighs are flexed and knee are also flexed. Both thigh and knee are flexed. This is complete breech. So PV findings here are buttocks, external genitalia in male fetus, anal sphincter and feet. That's complete breech or flex breech as written in the option. The frank breech is most common variety of breech where the thighs are flexed and knee are extended. PV findings are buttocks, anal sphincter, external genitalia in male but not the feet because feet are high up. So most common variety of breech is frank breech. The safest breech is frank breech. So assisted breech delivery can be tried in frank breech. How? How the legs are delivered? By pinard. What is pinard? We press popliteal fossa and legs are delivered. We press popliteal fossa and legs are delivered. So how to deliver lower limbs in frank breech? By Pinard's maneuver. We are pressing popliteal fossa. Fine. Knee breech, where thighs are extended and knee is flat. What is a footling breech? Thigh is extended, knee also extended. So maximum risk of cord prolapse is in which breech? Footling breech. So most dangerous breech is which breech? Footling breech, because of maximum risk of cord prolapse. So option D is incorrect, which says all the breech are due to same etiology. No. All the breech have same management. No. All the breech have different etiology. All the breech have different management. So most dangerous breech is footling breech. But overall, maximum risk of cord prolapse is in which presentation? Transfer. So transfers will be a better answer than footling breech. Among breech, maximum risk of cord prolapse is in footling breech. Fine. Let's move to the next question. Let us see these images also. There are various variations of breech. This is complete breech, this is incomplete breech, and this is frank breech, as shown in the image here. This is the Pinard's maneuver. How we deliver the lower limbs here? We are pressing popliteal fossa to deliver the lower limbs in frank breech or extended breech. How the aftercoming head is delivered in breech? By Piper's forceps. In developed countries like America, they are the longest forceps because they have a long perineal curve. But in India and other developing countries, aftercoming head is delivered by Burn-Marshall method. Burn-Marshall. This is Burn-Marshall method, where we allow the baby to hang first. Then we rotate the trunk over maternal anterior abdominal wall. So head in breech is delivered by flexion. Head in breech and face is delivered by flexion, while in cephalic presentation, head is delivered by extension. Very important question, beta. Head in cephalic is delivered by extension, while head in breech and face is delivered by flexion. Fine. Neurons which are wired together, they are fired together. This sentence is very close to my heart. And this Bitia, Dr. Juhi Sompura, All India Rank 1, has really proved this sentence. I still remember when she came to MIST, we got the opportunity to have a chit-chat with her for 4 to 5 long hours. And I still remember that sentence, what she said, sir, 15 days before exam, I was just scrolling the pages of workbooks. She said she was just going through all the pages of workbook 15 days before exam. एग्जाम से 15 दिन पहले ये बिटिया केवल वर्कबुक के पेजेस को टर्न कर रही थी, अपनी आईज को शब्दों के ऊपर से निकाल रही थी, so that that particular sentence can be recalled beautifully in exam hall. And she proved this. She was doing wiring of her neurons 15 days before exam. This is the update, beta. The name of PCOS has been changed to PMOS. The old name was polycystic ovarian syndrome and the new name is polyendocrine metabolic ovarian syndrome. Polyendocrine metabolic ovarian syndrome. Let's move to question number 2. The house is yours. I am hiding myself. मैं छुप जाता हूं जिससे प्यारे बच्चे इतना लंबा क्वेश्चन पढ़ सकें. Many students said, sir, in last exam there were very long questions. Even mouse was not working. We were just scrolling the cursor and still we were not able to read the question. Read the question here as if you are reading the question in examination hall. मैं छुप जाता हूं बच्चों के लिए. All of the following statements regarding placental and cord umbilical cord are true except. देखते हैं. In placenta accreta spectrum, defective nitabuclear permits abnormal trophoblastic adherence or invasion. Planned preterm cesarean hysterectomy without attempted. All of you are answering. All of you answered first question very well. I will see the answers given by you for question number 2. Option A, in placenta accreta spectrum, defective metabolic layer permits abnormal trophoblastic adherence or invasion. Plant preterm cesarean hysterectomy without attempted placental removal is standard for confirmed invasive disease. ओ भैया बहुत बड़ा ऑप्शन है. वी आर प्रिपेयरिंग अवर सेल्फ फॉर 28 जून एग्जाम ना. करना है ना बेटा. ऑप्शन बी पढ़ेंगे, यहां पढ़ने की आदत डालेंगे जिससे कि वहां बड़ा चॉकलेट नजर आएगा. Filamentous cord insertion may result in vasa previa and management is plant cesarean delivery. ओ इतना लंबा भूत जैसा घोस्ट लाइक ऑप्शन बिफोर लेबर रप्चर ऑफ मेम्ब्रेन्स. ऑप्शन नंबर सी, सांस न फूलने लगे बेटा ऑप्शन पढ़ते पढ़ते आराम आराम से. A single umbilical artery is associated with increased risk of structural anomalies and may be associated with trisomy 18, and we will learn how to crack the answer with such a long options in few seconds only. कुछ ही सेकंड में इनका आंसर निकालना सीखते हैं अभी. ऑप्शन नंबर डी, in placenta previa with active bleeding, digital vaginal examination is required to localize the placental age and guide delivery and induction of labor with amniotomy, which is ARM, is first line management. बताओ आंसर क्या है? वाह मेरे प्यारे प्यारे बच्चों, वाह मेरे प्यारे प्यारे बच्चों. थैंक यू मयंक ओबीजी बिकम चॉकलेट विद अमित सर. थैंक यू. इतने बड़े क्वेश्चन का तुमने इतना बढ़िया और इतनी जल्दी आंसर कर दिया. PV is contraindicated in placenta previa. Mayank Singh, big chocolate for you, Mayank Singh. Big chocolate for you, Mayank Singh. PV is contraindicated in placenta previa. That's why the correct answer is option D. देखो बेटा, placenta accreta spectrum, keyword देखा हमने. It is due to absence of metabolic membrane. Option A correct. Filamentous cord insertion results in vasa previa, we know. And in vasa previa, we never allow vaginal delivery, otherwise there will be massive bleeding. Wonderful. Single umbilical artery associated with 18. So connect single artery with 18. Option is correct. Like this. In placenta previa, just see the keyword. What examiner is writing? Digital vaginal examination is required. यहीं पे कहानी खत्म. Here only the story ends. यार इतना दिमाग का दही बनाने का जरूरत ही नहीं है. What is written in placenta previa? One keyword. Second keyword, digital vaginal examination is required. Not at all. We have clearly written PV, PS, they are contraindicated in placenta previa. So answer is option D only. Simple सी बात. But I am really very happy कि बच्चों ने, मिस्टियंस ने कितना conceptually पढ़ा है. How conceptually all the Mistians have studied here. I can see the answers and I am really very, very happy. Gajraj Singh Gurjar, 100%. That's correct. Just by getting one keyword, we are arriving at the most appropriate diagnosis. Let us go through few things here. This is placenta accreta. We know metabolic membrane is present between placenta and uterine walls. So this is normal. What is accreta? A means attached. Where placenta is attached to uterine wall. A attached. A attached. Most common variety of morbidly adhered placenta is placenta accreta. In invade grade 2 and percreta if it is reaching up to serosa and other pelvic structure. This is filamentous insertion of cord where cord is inserted on fetal membrane. Umbilical vessels are traversing in the membrane and reaching placenta. It results in vasa previa. And this is placenta previa where vaginal examination is absolutely contraindicated. But we have discussed in our classes very well. We have clearly written in our notes, PV is contraindicated in placenta previa, but investigation of choice for placenta previa is which ultrasound? Transvaginal sonography, TVS. Wonderful. Missed RRR, that's the beauty of read, repeat, revise, read, repeat, revise, read, repeat, revise. प्यारे प्यारे बच्चों, I can really see these answers and I am very, very happy कि मिस्ट के बच्चों ने क्या कमाल से कंसेप्चुअल ऑब्सगाइनी पढ़ा है. हाउ कंसेप्चुअली मिस्टियंस हैव स्टडीड ऑब्सगाइनी एंड यू आर क्रैकिंग सच ए लॉन्ग क्वेश्चन जस्ट इन फ्यू सेकेंड, क्योंकि हमने क्लास में समझा है कि किस कीवर्ड को किस कीवर्ड से कनेक्ट करना है और क्विकली आंसर लेना है. दैट्स द ब्यूटी ऑफ मिस्ट. रीड, रिपीट, रिवाइज, read, repeat, revise, and this बिटिया has really proved it. 15 days before exam, she was just doing missed RRR, missed RRR, missed RRR, read, repeat, revise, read, repeat, revise. What? The same content. She was scrolling the pages of same 19 subject workbooks of missed just 15 days before exam and see the happiness. चेहरे पे इस खुशी को लाने के लिए पढ़ना होगा हमें, और ऐसी ही खुशी हमारे मम्मी पापा के चेहरे पर भी आएगी जब हम RRR करके पढ़ेंगे, सेम कंटेंट को एग्जाम से 15 दिन पहले बार बार पढ़ेंगे. लुक हियर, सी द हैप्पी फेसेस. मैं छुप जाता हूं थोड़ा सा सो दैट यू कैन सी. इस खुशी के लिए हमको पढ़ना होगा बेटा. सी, ये पिक्चर्स हमें मोटिवेट करती हैं. दीज पिक्स मोटिवेट अस. These pics allow us to study more and more, more and more, more and more. थोड़ा सा और पढ़ेंगे. आज टारगेट पूरा अचीव नहीं हुआ, कल करेंगे. We'll achieve the target next day. थोड़ा सा जोर और लगा दो बेटा. कुछ ही दिन बचे हैं. MIST has given you a study plan. All these students followed MIST study plan like anything, and we really prepared that study plan very meticulously बेटा. Whatever subject we have advised you to study in the morning, afternoon, evening, night, MCQ solving skills and everything, please follow Mistians and non-Mistians, everyone, that MIST study plan that has been prepared very meticulously just for you, because we just have one intention in our heart, that every FMG should pass the exam. Every FMG should pass the exam, because जलने वाले जलते हैं, जलना उनका काम है. जला जला कर राख कर देंगे, FMG हमारा नाम है. चलो जी, कम, लेट्स कम टू क्वेश्चन नंबर 3. फिर से छुपना पड़ेगा बेटा मुझे, क्योंकि लंबे क्वेश्चन पूछने की आदत पड़ गई है NBE को. आई एम हाइडिंग माई सेल्फ. All of the following statements regarding stages of labor and management are correct except first stage, from onset of true pains to complete cervical dilatation. Delayed latent phase management is therapeutic rest. Delayed active phase management is ARM and oxytocin. After ruling out CPD and Occipito-posterior position. Active phase arrest management is cesarean section. That's option A. एक ऑप्शन में बेटा पूरा कंसेप्ट लिख दिया है. I took a long time to prepare these questions बेटा. In 2.5 to 3 hours OBG का जूस पी जाएंगे हम. Second stage, from full dilatation to delivery of baby. There are how many cardinal movements in second stage of labor? 7. Third stage is a stage of placental separation via uterine contraction, which is called AMTSL. Active management includes oxytocin, delayed cord clamping, control. मेरे प्यारे प्यारे बच्चों, अहमद गौर, अभिजीत, राहुल, पराग, जितेंद्र कुमार, मनश्री, विशाल, मुकेश, महेंद्र, चित्रा, गजराज, अनिल बिश्नोई, डी, एवरीवन डी. वाह मेरे प्यारे प्यारे बच्चों, लेट्स कनेक्ट द कीवर्ड्स. मेरे को सबसे ज्यादा खुशी केवल इसी बात की है कि किस ब्यूटी के साथ मिस्टियंस ने एक एक कीवर्ड को जो हमने क्लास में पढ़ा था उसको कनेक्ट करके मोतियों की माला बनाना सीख लिया है. एक टीचर के लिए इससे अच्छी खुशी की बात क्या हो सकती है, क्योंकि ये सारे के सारे क्वेश्चंस बेटा पेड़ के नीचे बैठ के बनाए हैं मैंने. आई प्रिपेयर्ड ऑल दीज क्वेश्चंस इन माय पार्क, विच इज माय वर्क जोन, जहां मेरा दिमाग चलता है. और ये पहली बार ये क्वेश्चंस बाहर आ रहे हैं. ये क्वेश्चन कहीं देखे भी नहीं होंगे. Very nice. First stage, so you connected beautifully. True pains to complete cervical dilatation. Second stage, delivery of baby. There are 7 movements. Third stage is placental separation, and we know what is the fourth stage. Fourth stage starts after placental expulsion. So, of course, this is the incorrect statement. This is the incorrect statement. Fine. Let us see these images. This is the image of controlled cord traction beta. This is image of controlled cord traction, which is modified Brent Andrews technique. Very important image question for our exam, where we have started pulling the cord At the same time, we are giving abdominal counter traction. So this is modified Brent Andrews technique asked as the image question. What is the most common method of placental separation? This is Schultz method, where placenta starts separating from center, so a retroplacental hematoma is formed and the bleeding is less. The other less common is Matthew-Duncan method, where placenta starts separating from periphery, so there is more vaginal bleeding. Most common method of placental separation is Schultz method. This is the modified Ridgen maneuver, which is recommended by WHO at the level of crowning to prevent perineal tear. What we do, first we do flexion and then extension. How to remember? F first, F flexion. F first, F flexion. First of all, flexion of head, then extension of hand. With other hand, we are supporting perineum to prevent perineal tear. Very important text question and image question recommended by WHO at the level of crowning to prevent perineal tear. Episiotomy is not mandatory in cephalic presentation. Episiotomy is mandatory in breech presentation, and in breech, episiotomy is given at climbing of perineum. At climbing of perineum. These pics are close to heart. Ghulam Nabi, I still remember. Wonderful students, beta. दिल खुश हो जाता है इनकी सक्सेस को देखने के बाद. Next question. I am hiding myself. मैं छुप जाता हूं फिर से. All of the following statements integrating. Fourth stage is after placental expulsion. Yes, beta. Fourth stage. Pixnomics. Mayank. Best line. Thank you, beta. After placental expulsion, fetal part comes out. Very good. Schultz smooth. Very good. All of the following statements integrating amniotic fluid physiology, disorders and management are true except after 20 weeks, amniotic fluid volume is primarily maintained by fetal urine, production and balanced by fetal swallowing. Oligohydramnios with absent kidneys and bladder suggests bilateral renal agenesis, which is correct statement, because cause of oligohydramnios is fetal renal problem. There is no urine production, and most common complication of oligohydramnios is pulmonary hypoplasia. Very important MCQ. So the whole topic is summarized in just one option, option A. देख लो बेटा आपके सामने है, मैंने पूरे कंसेप्ट को एक ही ऑप्शन में समराइज करके अलग रख दिया. पेड़ के नीचे बैठ के बनाया क्वेश्चन. ऑप्शन बी, पॉलीहाइड्रोनियोस में रिजल्ट फ्रॉम इंपेयर्ड फीटल swallowing, esophageal atresia etc. और increased fetal urine output. सिंपल सी बात है, because the balance of amniotic fluid is with swallowing and micturition. You have already started answering D. Wonderful, beta. Wonderful. I am really very happy. In polyhydramnios due to uteroplacental insufficiency, primary mechanism is increased fetal urine production. No, the answer is what happens in uteroplacental insufficiency? Oligohydramnia. Polyhydramnios does not occur. Option D. Wonderful. Polyhydramnios does not occur. This is oligohydramnios which develops. Very nice. So answer is option D. With uteroplacental insufficiency means hypertension. Hypertension results in oligohydramnios, not the polyhydramnios. Option C, severe oligohydramnios may be managed expectantly with hydration and close monitoring in selected intrapartum cases. Amnio infusion may reduce variable deceleration. Very nice. So severe oligohydramnios हम इसी तरह से मैनेज करते हैं बेटा, क्योंकि रिकरेंट वेरिएबल डेसिलरेशंस होते हैं इन सीवियर ओलिगोहाइड्रामियोस. सो विदाउट एनी डाउट इट इज ऑप्शन डी. और सबसे अच्छी बात है, बच्चे पहले से ही आंसर किए जा रहे हैं. एंड हाउ डू वी असेस ओलिगोहाइड्रामियोस एंड पॉलीहाइड्रामियोस? विद amniotic fluid index. We check the pockets of amniotic fluid in 4 quadrants. The largest pocket is called single deepest pocket. If you add it up, it is amniotic fluid index or AFI. These pics motivate us. Few pics with recently passed students. We got the opportunity to get these pics, beta. Your lovely Kunal sir, your lovely Saha sir. ये देखो बेटा, and see the happiness on parents' face. Parents के face पे ये खुशी देखो बेटा. See the happiness. इसी मोमेंट के लिए बिटिया ने इतना पढ़ा था, so that she can see this happiness on parents' face, because parents had a dream when they sent you to your respective overseas university, in the anticipation, in the hope that one day they will feel proud and they will have this moment to live. इस पल को जिएंगे वो एक दिन, और इस बिटिया ने अपने मम्मी पापा को ये पूरा मौका दिया कि इस पल को वो जी सके. Question number 5. Which of the following statements regarding this condition is false? Immediate manual replacement of the inverted uterus, Johnson method, is the first line life-saving intervention. So, first method for management of uterine inversion is Johnson method, we know, and uterine inversion is due to mismanaged third stage of labor. So, this option is correct. The question asks false statement. This is correct statement. Administration of uterotonic agents prior to uterine repositioning facilitates reduction by improving biomaterial tone. No. Beta, let me check. What do you say? Option D, excessive traction on the umbilical cord. No, option D is not the answer. Amit sir, great human being. Thank you, beta. Thank you so much. I passed January 26 last December time. Same evening, watching your session. Thank you so much. Thank you so much. Word gaming. Thank you so much. Thank you. Thank you very much. These pics motivate. Thank you, beta. Thank you so much for motivating me also. मैं भी मोटिवेट होता हूँ if you are writing that these pics motivate you. So I also feel motivated with this. So what is the answer to this question? Option B. Very good. Administration of uterotonic agents prior to uterine repositioning. No. It is done after uterine repositioning ना, क्योंकि uterotonic agents oxytocin will cause contraction of uterus. Then how can you put placenta inside then? नहीं ना, तो पहले we'll put it inside then. Neurogenic vagal shock may contribute to hemodynamic instability, bradycardia and hypotension independent of blood loss. It is because of stretching of nerve fibers. So pain is due to neurogenic shock in uterine inversion. Correct statement. Excessive traction on the umbilical cord prior to placental separation is a well-established cause of inversion. We know that's why we start pulling the cord once we are sure that placenta has been separated from uterine wall. And what is the best abdominal sign of placental separation? Uterus becomes firm globular, and the best vaginal sign of placental separation, you can feel placenta in vagina. Once you have these signs, then only you start pulling the cord, and the method is controlled cord traction or modified Brand and Reuse technique. Modified Brand and Reuse technique. Excessive traction on umbilical cord prior to placental separation is a well-established cause of inversion. So, answer is D. It is not done prior to, it is done after putting it inside. Oxytocin is injected after putting it inside. This is uterine inversion. Uterine inversion is due to mismanaged third stage of labor. This is first degree inversion where you can see just dimpling, second degree up to internal loss, third degree inversion up to external loss, and in fourth degree whole uterus turns inside out. This is called uterine inversion. So inversion is due to mismanaged third stage of labor, while uterine prolapse is due to mismanaged second stage of labor. No confusion, beta. Uterine prolapse is due to mismanaged second stage of labor, while uterine inversion is due to mismanaged third stage of labor. And what is the first step in management of uterine inversion? Manual reposition of uterus inside. This is called Johnson method. And what we revised just now, that we are giving oxytocin, uterotonic after repositioning of uterus, not before that. Oxytocin बाद में देना है. Then we separate placenta. It is put inside without separating placenta. We give oxytocin, uterus contracts, then we will separate placenta. Because most important factor in placental separation from uterine wall is uterine contraction. This is why most important aspect in management of third stage of labor is uterotonic injection. Drug of choice is oxytocin, 10 international units by intramuscular injection. 10 international units by intramuscular injection, and it has to be given maximum within 1 minute time. Very, very important MCQ zone because it is done to prevent PPI. Why most important aspect in management of third stage of labor is injection oxytocin? Because most important factor for placental separation from uterine wall is uterine contraction, And who will do uterine contraction? Injection oxytocin. Fine. Again, your lovely Kunal sir and Saha sir. ये पिक्चर्स हमें मोटिवेट करती हैं बेटा. फाइन, मजा आ रहा है ना देख के. आई स्टिल रिमेंबर हिम. He used to meet me during the classes and say, sir, आपका साइन लेने आऊंगा वर्कबुक पे. Many students take the signatures on workbook. I still remember him. सर, आपका साइन लेने आऊंगा वर्कबुक पे, लेकिन पास होने के बाद. अभी तक इसका सेंटेंस याद है. आपका साइन लेने आऊंगा वर्कबुक पे, लेकिन पास होने के बाद. सल्यूट बेटा, सल्यूट टू योर कॉन्फिडेंस. फाइन, लेट्स मूव टू नेक्स्ट वन. क्वेश्चन नंबर 6. मुझे फिर छुपना पड़ेगा. Question number 6. Very good. I'm very happy with your answers, beta. Sir, will these questions be helpful for upcoming NEET PG? Beta, the board is same NB and board is same for FMG and NEET PG. And let me share with very important thing, beta. मैं सोच रहा था नाम भी नहीं लूंगा, बोलूंगा भी नहीं, but तुमने NEET PG word use कर दिया. We are really overwhelmed with the response for the admissions in NEET PG batch, which MIST has started. MIST is starting online live batch for NEET PG from mid-July. So thank you very much for the overwhelming response for the admissions in online live batch of MIST. मैं नाम भी नहीं लेना चाह रहा था, लेकिन आपने बोल दिया कि will these questions be helpful for NEET PG? बेटा, the board is same and B, you know, इससे ज़्यादा मेरे मुँह से मत कहलवाओ. A 29-year-old G2P2 woman undergoes an apparently uncomplicated vaginal delivery at term. The third stage is actively managed and the placenta is delivered intact with membranes complete on inspection. Within minutes, she develops profuse bright red vaginal bleeding with rapid pooling noted on the back. She becomes tachycardic, heart rate 128 per minute, and hypotensive, blood pressure 86/54 millimeters of mercury. On examination, uterus is boggy, enlarged and not contracted. Tranexamic acid, oxytocin infusion and repeated uterine massage does not alter bleeding. Okay. No obvious external perineal tear is immediately visualized. Which of the following statements regarding this clinical scenario is incorrect? Beta, I hope everyone has understood, because within minutes she is developing bright red vaginal bleeding. So it is happening after delivery, so it is postpartum hemorrhage. The drug of choice to prevent PPH, oxytocin, has been given. Tranexamic acid to control bleeding, which is antifibrinolytic, has been given. And these drugs are given with uterine massage. Everything has been done, but there is no response. Bleeding does not stop. And there is no perineal tear. Placenta has also been completely expelled out. So it is not a case of retained placenta. So undoubtedly, this is a case of uterine atony, because placenta is delivered intact with membrane. So this PPH is not due to retained placenta. This PPH is not due to any perineal tear. So undoubtedly this postpartum hemorrhage is uterine atony. अमित सर, मिस धुरंधर, नहीं बेटा, मैं तो बहुत छोटा सा एक मास्टर हूँ बेटा, एक छोटा सा टीचर हूँ बेटा. थैंक यू सो मच, थैंक यू सो मच बेटा. किसने लिखा ये? सब साहब सिंह. थैंक यू सो मच बेटा. Next step in management of above condition is misoprostol followed by carboprost. Yes, beta, we know, because there is no response with oxytocin, tranexamic acid. The next step is misoprostol, and if there is no response after misoprostol, then we give carboprost. So I have put 2 and 3. If no response with oxytocin, then misoprostol is given. If no response with misoprostol, then carboprost is given. The drug of choice to prevent PPH is oxytocin. The drug of choice to treat PPH is also oxytocin. The best drug or the most powerful drug to treat PPH is carboprost, 15-methyl PGF2 alpha, 250 microgram intramuscular injection, and maximum 8 doses are given in 24 hours. We know that. So total 2000 microgram dose is given. If PPH is not controlled, so this statement is correct. Option B, if PPH is not controlled by above measures, next step is uterine tamponade. This is also correct. Atony remains the most probable cause etiology of PPH. That's also where all the statements are super duper important as well for our exam. मैंने बेटा ऑप्शंस भी उसी तरीके से प्रिपेयर किए हैं कि एवरी ऑप्शन इज अ पोटेंशियल क्वेश्चन फॉर अपकमिंग 28 जून FMG एग्जाम. यू कैन सी, सब कुछ आपके सामने है, कितनी मेहनत की होगी आपके टीचर ने पेड़ के नीचे बैठ के. If PPH is not controlled by hysterectomy, next step in management is devascularization of vessels. This is incorrect. Devascularization कब करते हैं बेटा? बकरी बैलून कैथेटर यूज. वेरी गुड, वेरी गुड. Devascularization is done after hysterectomy or before hysterectomy? I am asking you beta, devascularization is done. Very good. Everyone answers D, and I am very happy to see your conceptual knowledge of obs gynae. बहुत खुशी है. Devascularization is done before hysterectomy and not after hysterectomy. It is done before hysterectomy. So that's an incorrect statement. This is the image of uterine tamponade. The most commonly used balloon is Bakri balloon catheter, and how much maximum saline is used? 500 ml. Both the statements are potential MCQs for upcoming FMG as well as NEET PG. Since you use the word NEET PG ना, तो मुझे बोलना पड़ा. These are uterine compression sutures. The most common are B-Lynch or Breech sutures. This is the peak of uterine tamponade. Maximum 500 ml saline is used, and the most common catheter is Bakri balloon catheter. If vitals are unstable after uterine tamponade, then we give external aorta compression and we are shifting her in operation theatre for devascularization of vessels. First, uterine artery ligation. If no response, utero-ovarian anastomosis ligation. If no response, ligation of anterior division of internal iliac artery. If no response, then we do hysterectomy. And which hysterectomy is done in PPH? Subtotal. Only uterus is removed. Cervix is not removed since she is a young reproductive aged lady. Since she is young reproductive aged lady. So we got some moments at the time of Holi with Shilpi ma'am. तो होली वाले दिन शिल्पी मैम का भी क्लास चल रहा था, मेरा भी क्लास चल रहा था. सो वी सेलिब्रेटेड होली विद द स्टूडेंट्स. वंडरफुल मोमेंट्स. These pics really motivate us. 500 ml, yes, yes, Paridhi. Bakri balloon, subtotal hysterectomy, that's wonderful. Carboprost, yeah, Carboprost, it is in management but not in prevention. It is in management, not in prevention. Not in prevention. Fine. Question number 7. मैं फिर से छुप जाता हूं. Let me hide myself. Obstetrician suspects a severe form of placental abruption with concealed hemorrhage and evolving consumptive coagulopathy. Which of the following statements regarding this condition is incorrect? It is a question of abruptio placentae. Let us just get the keywords better. I have passed my FMG. Thank you, Naved Pradhan. The magnitude of external vaginal bleeding may significantly underestimate the true volume of hemorrhage due to retroplacental sequestration. Correct statement, because it is concealed abruption. So we do not know how much blood is there inside. Option B, hypertension contribute to decidual arteriolar vasospasm and predisposed to premature placental separation. That's also correct. Hypertension is a risk factor for abruptio placentae. Yes, yes. Then what you are answering, uterus is typically soft. Beta, I am really very happy. I am really happy that you have really learnt of art of solving long clinical questions. मजा आ रहा है, दिल खुश हो गया. Just because of one keyword, मेरे प्यारे प्यारे बच्चों, soft, compliant and non-tender. Such a इतना लंबा question, इतने लंबे option. Such a long question, such a long option. But just with one keyword, placental abruption, my loving students know in placental abruption, uterus is hard and tender. Uterus is hard and tender. And what is mentioned here? Soft and non-tender. So this is obviously incorrect. यहां से मोतियों की माला शुरू की, यहां पे खत्म कर दी. कितनी जल्दी हमारे कितने सेकंड्स पे. टाइम मैनेजमेंट इज very important, you know. Many students said, sir, don't give 300 minutes for mock test because we really waste 5 to 7 minutes in first paper and 5 to 7 minutes in second paper. So just give them 285 to 290 minutes. So all the students be ready for your mock 3 on 26th of May. We will not give you 300 minutes. हम 300 क्वेश्चन के लिए 300 मिनट नहीं देंगे और वो क्वेश्चन भी पेड़ के नीचे ही रिव्यू हुए हैं बेटा. तो तैयार रहना मॉक 3 के लिए. Uterus is hard and tender. It is not soft and non-tender. Fetal distress may occur due to uteroplacental insufficiency due to hypertension. So the correct answer is C. कितनी जल्दी हमने इसको correct कर दिया. And all of you, uterus is tender. Very good. Very good. See, this is the image of placental abruption where this placenta is detached from, this is uterine wall and this is placenta. Since this placenta is detached from uterine wall, you can see the blood clot in between. This is abruptio placentae. And what happens in abruptio placentae? Covaliar uterus develops, which is also called uteroplacental apoplexy, where you can see this retroplacental blood enters biometrium and reaches up to serosa. So when you open up in cesarean section, you see a wine-colored or a bluish-red uterus. So bluish-red or wine-colored uterus indicates covaliar uterus. Other name is uteroplacental apoplexy. It is seen in which condition? It is seen in concealed variety of abruptio placentae. Wonderful. Yeah. Take every mistake in test as an opportunity to learn. Don't feel disheartened with the marks of your test, whether it is a subject-wise test or a mock test. Just take a pledge. My tomorrow is better than my today. मैं अपने कल को अपने आज से बेहतर बनाऊंगा. And all these students did the same. इन सारे बच्चों ने बेटा यही किया था. मैं छुप जाता हूं. इन सारे बच्चों ने यही किया था. All these students did the same. They took the pledge if they scored less marks in test that my tomorrow is better than my today. आज के मॉक टेस्ट के मार्क मेरी पढ़ने की हिम्मत को टूटने नहीं देंगे. मैं अपने कल को अपने आज से बेहतर बनाऊंगा और ऐसे ही सर से मिलने जाऊंगा. एग्जाम को पास करने के बाद 28 जून का. ठीक है ना बेटा? जितने भी दिन हैं उतने दिन में आग लगा देंगे पानी में. आग लगा देंगे पानी में. चल. योर लवली विनीश सर, जो इंसान सर्जरी को रसगुल्ला बना सकता है उसके बारे में क्या ही बोलो. चल. नेक्स्ट वन. Which of the following statements is incorrect? Vacuum is preferred over forceps in management of deep transverse arrest. Correct statement. Why vacuum is preferred over forceps in deep transverse arrest? Because vacuum, due to negative suction pressure, promotes auto-rotation. So vacuum is preferred to manage deep transverse arrest, not the forceps. But the best management for deep transverse arrest is cesarean section. Why vacuum is preferred over forceps? Because due to negative suction pressure, vacuum promotes auto-rotation. So it is preferred to manage deep transverse arrest. Vacuum can be safely applied on fetal sagittal suture. Very good, very good. Thank you, Anushka. Thank you very much. Vacuum can be safely applied on fetal sagittal suture before full cervical dilation, as long as the fetal head is engaged. We know vacuum can even be applied if cervical dilatation is just 6 cm, while forceps application is done if cervical dilatation is 10 cm. Most commonly used forceps are outlet forceps, Wrigley's forceps, and are applied at +3. Forceps may be applied in unrotated. All of you are answering, yeah, Vinesh sir, yeah, Vinesh sir, yeah. No one in the world can teach surgery like him. जो इंसान सर्जरी को रसगुल्ला बना दे उसे कहते हैं विनीत सर. वेरी गुड, वंडरफुल. डी एवरीवन. बिकॉज ऑफ जस्ट वन कीवर्ड मेरे प्यारे प्यारे बच्चों, वी नो फॉरसेप्स में कोई प्रेशर नहीं होता ना, नेगेटिव सेक्शन प्रेशर. सो फॉरसेप्स डू नॉट प्रमोट ऑटो रोटेशन. इतना लंबा क्वेश्चन देख के डिसहार्टन नहीं होना. जस्ट गेट द कीवर्ड. फॉरसेप्स अनरोटेटेड हेड. नो, नहीं ना, हो ही नहीं सकता. There is no negative pressure. So how you can apply forceps in unrotated head? You need complete rotation of head. Then only you can apply forceps. How will you apply in unrotated head? No way na, nahi ho sakta. So correct answer is D. Vacuum can be applied even when cervical dilatation is just 6 cm. Just 6 cm. And how much is the optimum suction pressure in vacuum? 0.8 kg per square centimeter, which is equivalent to 600 millimeter of mercury. But the drawback of vacuum is it cannot be applied in prematurity less than 34 weeks. There is more risk of injury to fetal parietal bone because it is applied 3 centimeter anterior to posterior fontanelle, which is the flexion point. So there is more risk of fracture of parietal bone. So that's the drawback of vacuum. This is vacuum, and this is the correct application of vacuum. The center of cup should be 3 centimeter from posterior fontanelle, and the perimeter of cup should touch posterior fontanelle. So two keywords here. Perimeter of cup should touch posterior fontanelle, and center of cup should be 3 centimeter anterior to posterior fontanelle. Yeah, all of you answered D. Yeah. सर्जरी को रसगुल्ला बनाते हैं एंड अमित सर ओबीजी को हलवा. Thank you so much, beta. So that's how we put the vacuum here, 3 centimeter anterior to posterior fontanelle. These are most commonly used forceps, outlet forceps or Wrigley's forceps. This is the longest forceps or Piper forceps used to deliver after coming head in breech in developed countries like America. All of them are potential important questions for our exam. This is episiotomy. How much is the angle in episiotomy? 60 degree is the ideal answer. If 60 is not an option, then 45 degree. Which episiotomy is preferred? Mediolateral, because incision can be extended if required. So which episiotomy is better? Mediolateral. So we discussed all the concepts. Again, few pics to motivate you. See the happiness on the face of parents, बेटा. पापा के चेहरे पे ये खुशी, बच्चों के चेहरे पे ये खुशी. मैं जरा छुपा लूं अपने आप को. Yeah. See the happy moments. We'll study, बेटा. फोड़ के रख देंगे बचे हुए दिन में. We'll read, repeat, revise, read, repeat, revise. We will follow missed study plan. We will follow missed RRR concepts, as all these loving students, including Juhi Bitia, did 15 days before exam. Exam से 15 days पहले workbooks, but those workbooks should be your own handwritten, conceptually understood workbook. आपकी अपने हाथ से लिखी हुई और क्लास में conceptually सुनी हुई workbook. और उस workbook को when you are revising, you have to revise with closed workbook also. So while revising the workbook, whatever you are revising, you are imprinting in your brain. Vikash Kumar, thank you so much. Thank you so much. Thank you, Anushka. Thank you so much. Next one. A 24-year-old woman presents with 10 weeks of amenorrhea and a positive urine pregnancy test. देखो ये वाला क्वेश्चन है ना, 3 keywords हैं, केवल 3 कीवर्ड. 10 weeks of amenorrhea and a positive urine pregnancy test. Transvaginal ultrasonography show the gestational sac with fetal pole without cardiac activity, and CRL is 10 mm. Let me check. What is the answer to this question? Mohit, thank you. Thank you, Mohit. I will be there soon. Thank you, Mohit. Waiting for you. Mohit, intezar tumhara. CRL is 10 millimeter. There is no history of pain or bleeding. What is the most likely diagnosis? Let me check what my loving students are writing. मेरे प्यारे बच्चे क्या लिख रहे हैं? मिस्ड विकास, वेरी गुड. शलभ, वेरी गुड. गजराज, मयंक, ननन, चेल्सी, चित्रा, वेदल खिल, परिधि, राहुल, धीरज. Wonderful, very nice. Everyone has given the correct answer. We know if we see embryo without cardiac activity, the CRL cutoff is 7 millimeter. If CRL is 7 millimeter or more and no cardiac activity is seen in the embryo, that is a missed abortion. How you will get a question of threatened abortion? What examiner will write for a threatened abortion question? She is coming with 10 weeks amenorrhea, positive urine pregnancy test. She gives history of mild bleeding per vaginum. Fundal height is equal to period of amenorrhea and internal os is closed. What is the diagnosis? Threatened abortion. And management of threatened abortion is bed rest and progesterone. Incomplete abortion question, how will you get? She presents with amenorrhea, positive urine pregnancy test. She is complaining of bleeding. Fundal height less than period of amenorrhea and internal os is open. Management is suction evacuation. Molar pregnancy, how you will get this question? Examiner will write amenorrhea, positive urine pregnancy test. One keyword for molar pregnancy will be fundal height more than period of amenorrhea because of more HCG, hyperemesis gravidera. In few questions, examiner may write there are features of thyroid toxicosis also. Examiner may give ultrasound appearance also as a keyword. Ultrasound of uterus shows snow-storm appearance. Whatever I spoke, each and every word is a potential question for upcoming FMG and NEET PG exam. So this is a missed abortion here. This is the image of blighted ovum. This is blighted ovum. If you see empty gestational sac, beta, without any yolk sac or embryo, the cutoff here is if mean sac diameter is 25 millimeter or more, and if the sac is empty, this is called blighted ovum. This is called blighted ovum or an embryonic pregnancy. This is missed abortion, where we see this is the ultrasound beam passing through the fetal heart and there are no waveform, it is a flat line. So this is a missed abortion. But the cutoff here is CRL should be at least 7 millimeter and no cardiac activity present. This is missed abortion. Examiner may give you this image. This is vesicular mole or hydrated deformed mole. You can see these vesicles which look like hydrated cyst. Examiner may ask which hormone is likely to be raised with the given image. Answer is HCG. And this is ultrasound appearance of complete mole, which is snowstorm appearance. Snowstorm appearance. Fine. Sir, explanation are best. Thank you. Thank you very much. HCG high in molar pregnancy. That's correct. Incomplete, os open. That's correct. Very good, Ved. Very good, Vedakhil. Very good. See, what I talked just now, our own conceptually understood and handwritten workbooks are real game changer. They should be our own conceptually understood and handwritten workbook. अपने हाथ से लिखी हुई, अकेला मैं नहीं कहता बेटा. All your teachers say this. आपके सारे teachers बेटा यही बात कहते हैं. All your mentors, all your teachers say that your own handwritten, conceptually handwritten workbooks, they are the real game changer. And nothing else should be studied 15 days before exam. Just follow the missed RRR, 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 read, repeat, revise, read, repeat, revise. अकेला मैं नहीं कहता, आपके सारे प्यारे प्यारे टीचर्स कहते हैं बेटा. Lovely Salman sir, I still remember once it was a Eid moment and I was in Hyderabad. So I am a vegetarian. So Salman sir especially came to hotel and Salman sir brought some aloo bonda for me and that sevaiya kheer, awesome, very rich sevaiya kheer. And sir said, my younger sister has especially prepared it for you. Hats off to Salman sir. ईद वाले दिन अपने घर से मेरे लिए वेजिटेरियन खाना बना के होटल लेके आए थे. भूलता नहीं कुछ भी बेटा मैं. Thank you sir. Thank you. So our own conceptually understood and handwritten workbooks are a real game changer. Question number 10. A 30-year-old pregnant woman, RRR, read, repeat, revise, read, repeat, revise. A 30-year-old pregnant woman with a history of 3 consecutive first trimester miscarriages. So get the keywords, 3 consecutive first trimester miscarriages, presents for antenatal care. On evaluation, she is diagnosed with antiphospholipid antibody syndrome, APLA syndrome. The most common antibody here is lupus anticoagulant. What is the most appropriate management? We know the keyword. If there is no history of previous abortion, we give aspirin only. And if there is history of previous abortion or thrombosis, we give aspirin with, let me check what you are answering, B. Very good. Very good. Pixel, very good, B. Wonderful. Answer is aspirin plus heparin. So what is the keyword here? Very important question for our exam. If there is no history of previous abortion or thrombosis, only aspirin is given. If history of previous abortion or thrombosis mentioned in the question, we give aspirin along with low molecular weight heparin. Very good. B, 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 B. Everyone B. Maza aa gaya. So this is cervical incompetence. We know what is the shape in cervical incompetence and preterm labor. It is U-shaped cervix. The most common method of management is cervical cerclage. The most commonly applied is McDonald stitches applied at cervico-vaginal junction. But the best cervical cerclage is modified Shirodkar, which is applied at the level of internal os. Since it is applied at the level of internal os, it is best, but it is difficult to perform. So most commonly performed cerclage is McDonald stitches, but the best cerclage is modified Shirodkar. Do active revision with active recall as if you are teaching yourself. In the coming days, beta, revision is an art, beta. Revision karna aana chahiye. Do revision like this. First of all, you open the workbook and revise. Just revise and then close the workbook. And then close the workbook and then just speak out from within inside. In Hindi, एक बार वर्कबुक को पढ़ने के बाद रिवाइज करेंगे ऑफ कोर्स, एंड देन वी विल क्लोज द वर्कबुक या अपनी आईज को क्लोज कर देंगे और फिर अंदर से बोलने की कोशिश करेंगे जैसे हम अपने आप को ही पढ़ा रहे हैं. दैट इज द बेस्ट मेथड फॉर रिवीजन. एंड ऑल दीज लविंग स्टूडेंट्स डिड द सेम. मैं अपने आप को छुपा लेता हूं जिससे आप बच्चों को अच्छे से देख लो. ऑल दीज लविंग स्टूडेंट्स डिड द सेम. Everyone did the same. They also revised the same way and they were here after passing the exam and see the happiness on their faces. इनके चेहरे की खुशी देखो बेटा. Next question. तो a multi-gravida woman, yeah, LMWH. Sir, history of previous abortion नहीं होगा तो एप्ला का डायग्नोसिस कैसे बनेगा? एप्ला हम सस्पेक्ट कर रहे हैं ना बेटा. वी आर रूलिंग आउट वेरियस कॉजेज. सो वी आर डूइंग मॉडिफाइड सेपोरो क्राइटेरिया और सिडनी क्राइटेरिया ना. हम टेस्ट करेंगे तभी तो बनेगा ना एंजल हक. अ मल्टी ग्रेविडा वुमेन हैज बीन इन द सेकेंड स्टेज ऑफ लेबर फॉर द पास्ट 2 hours. ऑन एग्जामिनेशन यूट्राइन कॉन्ट्रैक्शंस आर एडिक्वेट. cervix is fully dilated. Fetal head is at station 0 with molding. So station, keyword, station is 0. With molding 2+ and kappa 2+ means fetus is compressed in birth canal. That's why molding and kappa have developed, because of compression of fetal head in birth canal. Head is compressed here in birth canal. The sagittal suture is in the right occipito transverse position, like this. It is in right occipito transverse position. Fetal heart rate is 140. What is the most appropriate management? Already it has been 2 hours. So what is the diagnosis? Deep transverse arrest. Already this is a case of deep transverse arrest. I am very happy. So what is the management for deep transverse arrest here? Lower segment cesarean section. Mid pelvic forceps delivery, they are never done, because most important prerequisite for vacuum or forceps application is a station should be at least +2. Mid pelvic forceps delivery, they are obsolete now. Vacuum assisted delivery is preferred over forceps, but the best method, lower segment cesarean section, is given in option. So what you will do lower segment cesarean section, no more waiting. Deep transverse arrest is already diagnosed. This is just from our Obs-Gynae workbook. So if you get this question regarding occipito-posterior position, you can see here the occipit is posterior. So if occipit is posterior, what are the findings? Infraumbilical flattening, because occipit is posterior. Limbs are felt in midline. Fetal heart sound, they are auscultated on sides, and fetal back is also shifted on side. So back and FHS sides में आ गया. Limbs are in midline since occipit is posterior. Beta, if occipit is anterior, if occipit is anterior, it gives a bulge here. Since occipit is posterior here, it gives you infraumbilical flattening. यहाँ गड्ढा हो जाएगा ना, क्योंकि occipit पीछे चला गया, पीछे की साइड में. So if you find the keyword infraumbilical flattening, FHS and back on sides and limbs in midline, what's the diagnosis? Occipito-posterior position, important image question for our exam. If examiner gives you this question, if a female presents with occipito-posterior position, what is the next step? Wait and watch, because we know. Most common occipito-posterior is right occipito-posterior. We are waiting for a good uterine contraction. Presenting part will be pushed down. As soon as it touches levator ani muscle, they will move it forward, medially, inward. That's internal rotation. So we are waiting for this 3/8 rotation, and it will deliver vaginally. So if a patient presents with occipito-posterior position, what is the next step? Wait and watch. So this is just from our Obs Gynae workbook. If what is written in the question, she presents with occipito-posterior position and the pelvis is android. So deep transverse arrest is common in which pelvis? Android. It is a heart-shaped pelvis. Because of prominent ischial spines here, what happens? The most common is right occipito-posterior. Because of prominent ischial spines, it just rotates 1/8. And because of ischial spines here, it is stuck here at the level of ischial spine. And if it is stuck here for more than 1 hour, despite of good uterine contraction and complete cervical dilatation, this is called deep transverse arrest. And the best management for deep transverse arrest is cesarean section. If cesarean section is not an option, vacuum will be preferred over forceps. Because of suction, vacuum promotes auto-rotation because of negative suction pressure. So vacuum is preferred over forceps. But what is the best management? Cesarean section. For android pelvis, we go for cesarean only. For DTA, vacuum may be tried in some other pelvis other than android. Yeah. If it is written that occipito-posterior position is with anthropoid pelvis. If the pelvis is anthropoid, what will be your questions? If it is anthropoid pelvis, there is no other way except to settle in direct occipito-posterior or persistent occipito-posterior position. If a good uterine contraction comes, it will go down like this. So persistent occipito-posterior or direct occipito-posterior position is common in which pelvis? Anthropoid. Phase 2 pubis delivery is possible in which pelvis? Anthropoid pelvis. Third very important question. Maximum difficulty in rotation of fetal head is in which pelvis? Anthropoid pelvis. All of them are super duper important questions for upcoming exam. Maximum difficulty in rotation of head is in which pelvis? Anthropoid pelvis. Direct and persistent occipito-posterior, anthropoid pelvis. Phase 2 pubis delivery, anthropoid pelvis. And deep transverse arrest was common in which pelvis? That was common in android pelvis because of prominent ischial spines. It was just stuck just after rotation by 1/8. Let's move. जलने वाले, this line is very close to my heart. जलने वाले जलते हैं, जलना उनका काम है, जला जला कर राख कर देंगे, एफएमजी हमारा नाम। एक बार फिर बोलता हूं, मजा आता है बोलने में मुझे। जलने वाले जलते हैं, जलना उनका काम है, जला जला कर राख कर देंगे, एफएमजी हमारा नाम है। यस, सी एंड इस बच्चे ने यही किया। मैं अपने आप को छुपाता हूं बिकॉज दीज इमोशंस आर वेरी इंपॉर्टेंट बेटा। दिस स्टूडेंट डिड दिस बेटा। सी द हैप्पीनेस ऑन द फेस ऑफ ग्रैंडफादर, ऑन द फेस ऑफ फादर, ऑन द फेस ऑफ चच्चा। चच्चा के चेहरे पे खुशी देखो, मम्मी के चेहरे पे खुशी देखो, पप्पा के चेहरे पे खुशी देखो, बब्बा के चेहरे पे खुशी देखो। हमको पढ़ना है, पानी में आग लगानी है, अपने घर के हर मेंबर के चेहरे पर इस खुशी को देखने के लिए। यस अनुष्का, जलने वाले जलते हैं, जलना उनका काम है। मयंक, माय टुडे, वेरी गुड, very good. My today is better than my yesterday. Very good. You modified my sentence. My today is better than my yesterday. Very good. Wonderful. चलो जी, let's move. Next question. मैं छुपा लेता हूं अपने आप को. All of the following statements regarding Müllerian anomalies are true except septate uterus results from failure of resorption of the Müllerian septum despite normal duct fusion and is associated with early pregnancy loss. Correct statement ना? Septate uterus कब होता है? When there is failure of disappearance of inner walls. So that's correct. Bicornate uterus results from incomplete fusion of Müllerian ducts and is associated with second trimester Loss, preterm labor, and malpresentation, we know. Bicoordinate uterus usually cause preterm labor, and it is because of failure of fusion of Müllerian ducts. So option A and B are correct. Uterine didelphys. Uterine didelphys results from complete failure of fusion of Müllerian ducts and often presents with double uterus, double cervix, and double vagina. Very nice. मेरे को तो सबसे ज्यादा खुशी इस बात का है. What I am feeling happy. The way we discussed obsgyny in the class, बेटा, जिस तरह से हमने क्लास में ओबीजी को पढ़ा, you have developed that art of matching the keywords and you are answering everyone unicornuate from one Müllerian duct. Yes, Mayank saying unicornuate from one Müllerian duct. Proud of you. So just with one keyword, from normal bilateral Müllerian duct, such a long question, such long options तुम्हारे अमित सर ने पेड़ के नीचे बैठ के बनाए जहां उनका दिमाग चलता है. मजा आ गया. सबसे ज्यादा खुशी है. आई एम प्रेटी कॉन्फिडेंट बेटा, all of you are going to perform very well in upcoming 28th June FMG exam, because the way you are answering OBG, I am pretty sure you will answer all 19 subjects like this on 28th June. Wonderful बेटा, मजा आ गया. We are assessing your test marks also. बहुत एक एक चीज को बड़ा meticulously follow कर रहे हैं, and we are pretty sure that this time also we are going to produce wonderful result as before. Chalo. So let us go through these images. This is unicornuate uterus HSG finding. So this is that unicornuate uterus, Mayank Singh, what you wrote, that it developed from one Müllerian duct. This is bicornuate and this is septate. We know they are far apart, so that's how we diagnose. ये थोड़े अलग-अलग जा रहे हैं. Bicornuate, septate, they are little vertical. So this is a septate uterus. This is arcuate uterus. Another important image question for our exam. This is Leach Wilkinson cannula, and this is laparoscopy for bicornuate uterus. Again, these pics motivate us. Let me hide myself so that you can see these emotions, क्योंकि ये emotions बहुत important है. See the happiness on the face of father. पप्पा के चेहरे पे इस खुशी के लिए पढ़ना है हमको. इस खुशी के लिए पढ़ना है हमें बेटा. Look here. Can you see them? नहीं सर, ऐसे फोटो खिंचानी है. नहीं सर, ऐसे फोटो खिंचानी है. We'll have one photo with this chocolate. We'll have the photo with Bumento. ये एंथू कैसे आता है बेटा? How these loving students get these enthusiasm, no? Just because that pressure is gone. वो जो प्रेशर, जो एक तलवार लटकी होती है चेहरे पे, वो चली जाती है. तब अंदर से मन करता है, सर एक फोटो ऐसे खिंचाएंगे, एक फोटो ऐसे खिंचाएंगे. आप सबका इंतजार है बेटा. We are waiting for you all. Next question. All of them, दोबारा छुपना पड़ेगा. All of the following statements regarding HPV pathogenesis, human papilloma virus pathogenesis, staging and management are correct except integration. Option A, integration of high-risk HPV DNA leads to overexpression of E6 and E7 proteins, promoting degradation of P53 and inactivation of retinoblastoma gene. Very good na beta. देखो how many MCQs we solved in just one option. Option A, we know very well that E6 suppress P53 and E7 suppress retinoblastoma gene. And we remembered that keyword also beta. 6 पहले आया, P पहले आया, 7 बाद में आया, R बाद में आया. So option A is correct. This is how we revised in the class. तुमने आंसर भी दे दिया. तुम यार वेरी गुड. द करेक्ट आंसर इज डी. आई एम रियली हैप्पी. मुझे तो लग रहा है मैं थोड़ा समझाऊं, थोड़ा डाइसेक्ट करूं, थोड़ा डिफरेंशियल डायग्नोसिस डिस्कस करूं, लेकिन बच्चे गुरु तो गुड़ी रह गए, चेले चीनी हो गए. वेरी गुड, वंडरफुल, वेरी हैप्पी. ऑप्शन बी, पैरामेट्रियल इन्वॉल्वमेंट विदाउट एक्सटेंशन टू pelvic side walls. वेरी गुड. Correspond to figure stage 2B. Correct statement. Concurrent chemoradiation with cisplatin-based therapy is the preferred treatment for this stage of disease 2B, because 2A2 onwards, the treatment is chemoradiation, 2A2 onward, and this is 2B. So option A, B, and C are correct. Let's have a look at option D. Radical hysterectomy with pelvic lymph node dissection is the standard first line treatment for all stages for 2B. No, because 2A2 onwards, what's the management? We know it is chemo radiation. Chemo radiation. So option D is incorrect statement. And this is the staging of cervical cancer we have mentioned. A1 less than 3 mm, A2 3 to 4, B1 5 or more than 5 mm but less than 2 centimeter, B2 2 or more than 2 but less than 4, B3 4 or more than 4. Stage 2A is divided in A1 and A2, A1 less than 4, A2 4 or more than 4, and what is 2B? Upper two-thirds of vagina with parametrial involvement, and what is mentioned here? It is 2B. Parametrial involvement. So parametrial involvement is 2B. Let's see these pics also. What is 2B? As you can see, this is going to parametrium. So parametrial extension, it is categorized as a stage 2B. बहुत खुशी हो रही है बेटा. Your lovely Vinny sir, your lovely Anupma ma'am for physiology and Dhawan sir for ENT. देखो बेटा, these pics मैं खुद छुप जाता हूँ so that you can see these emotions. See the emotions. बिटिया के चेहरे से केवल खुशी का अंदाज मत लगाओ, केवल अपने लिए नहीं पढ़ना, जरा पप्पा के चेहरे की खुशी को देखने की कोशिश करो. Try to see the emotions on father's face. पप्पा के चेहरे पे इन इमोशंस को देखो बेटा. टीचर्स को कितनी खुशी हो रही है. मुझे तो पिक्स दिखाने में बहुत अच्छा लग रहा है. आई एम फीलिंग मोटिवेटेड. आई एम फीलिंग मोटिवेटेड. फाइन. नेक्स्ट क्वेश्चन. क्वेश्चन नंबर 14. थोड़ा छुप जाऊं यार, मेरी शक्ल देख के क्या करोगे. All of the following statements regarding the pathophysiology and management of these conditions are correct except. ऑप्शन ए. फिर एक चीज देखना बेटा, तुम्हारे इस छोटे से टीचर ने बहुत मेहनत की है पेड़ के नीचे बैठ के, एक ही ऑप्शन में पूरा टॉपिक डाल दिया. Endometriosis is ectopic endometrial glands and stroma with cyclic bleeding. The keywords, the clinical triad of endometriosis is dysmenorrhea, dyspareunia, and infertility. This is the clinical triads. If you find these three keywords in an option, in a question, the diagnosis is endometriosis. Treated with non-steroidal anti-inflammatory drugs and OCP. First line management for endometriosis for mild pain is NSAIDs with OCP. Then we go for progesterone, no response, then GnRH. If there is failure to medical management, then only we go for laparoscopy. यार मैं तुम्हें पढ़ाने में ही लगा हूं और तुमने आंसर भी कर दिया. यू हैव आंसर्ड ऑल्सो डी. एक बार यार तुम्हारे सामने अपने लिए तो ताली बजा लूं. I was not expecting. Although I was pretty sure the way we studied obs-gynae in the class, I was pretty sure that you will match the keywords. मेरे को उम्मीद तो थी कि तुम सीख तो गए होंगे, but why I was not that sure? Because you are passing through all the tests, you know. You are just done with PSM. मजा आ गया. तालियां आपके लिए, अपने लिए बजा के क्या करूंगा. चलो. Adenomyosis, invasion into myometrium, menorrhagia. If you see these two keywords in a question or an option, menorrhagia and dysmenorrhea, the diagnosis is adenomyosis. And what is the treatment of choice for adenomyosis? This is hysterectomy. Endometrial polyp, they are focal endometrial mucosal growth. So what is a polyp? It is a mucosal growth. And what is the ultrasound color Doppler sign? It is feeder vessel sign. Feeder vessel sign. And how do we diagnose? Investigation of choice is hysteroscopy and treatment of choice is also hysteroscopy. तो मैंने थोड़ा सा गुगली खेल के थोड़ा सा दाएं बाएं कर दिया. So these three options are correct. Endometriosis, adenomyosis, so we revised endometriosis, adenomyosis and polyp. इसके बाहर कुछ आएगा भी नहीं एग्जाम में. बात कर लेंगे 28 की शाम को. इन तीन टॉपिक्स की बात कर रहा हूं. Endometriosis, adenomyosis and polyps share identical etiology and respond. नहीं, endometriosis is due to high estrogen, adenomyosis is due to invasion of endometrium into myometrium, and polyps, they are more common in menopausal age, they are mucosal growth. So they have different etiology. This is endometriosis. The ovarian cyst appearance in endometriosis is ground glass. Another important question. First line management for mild pain, NSAIDs with OCP. If no response, then progesterone. If no response, then GnRH. These are laparoscopy findings in endometriosis. This is early lesion, which is called red flame lesion. This is late lesion, which is called gunshot or powder burn. Our Ops Gynae workbook, which is your own handwritten, conceptually written. You all studied Ops Gynae conceptually. That's why you are able to answer so quickly here. I can see बेटा, हर चीज में एफर्ट लगता है, हर चीज में मेहनत लगती है. यूं ही कुछ नहीं मिल जाता इस दुनिया में. आपने पढ़ने के लिए अपने आप को पकाया है, बहुत सारे सेक्रीफाइस किए हैं, इसलिए बी और डी और ए आप जल्दी जल्दी आंसर कर पा रहे हो. दिस इज अनदर इंपॉर्टेंट इमेज क्वेश्चन फॉर अवर एग्जाम. If they give this laparoscopy image, they are gunshot or powder burn, so the diagnosis is endometriosis. What is the laparoscopy appearance of ovarian cyst? Another very important question, chocolate cyst. So this is chocolate cyst. This is adenomyosis. If they give this image, hysterectomied specimen. Nowadays, there is fashion of asking hysterectomied specimen as a MCQ. So adenomyosis uterus is red. It is symmetrically enlarged tender uterus, Halban sign. Halban sign is seen in adenomyosis, Halban theory in endometriosis. Halban repair is for enterocele. But best repair for enterocele is McCall caldoplasty. Beta, whatever I am speaking in this session, each and every word, if I am jumping from one topic to other, that's a potential question for that topic. And you will just match my words, match my keywords on 28th June evening. 28 जून को मेरे इस सेशन के कीवर्ड्स को भी मैच कर लेना बेटा. सी द हाइट ऑफ कॉन्फिडेंस ऑफ योर टीचर. अपने टीचर का कॉन्फिडेंस देख लो. दिस इज हिस्ट्रोस्कोपी इमेज ऑफ सबम्यूकस फाइब्रॉइड. This is HSG image of submucous fibroid, solitary regular filling defect. But in Asherman syndrome, it is multiple irregular filling defect. So in Asherman, that is Moth-Eaton appearance. This is hysterectomied specimen of uterine fibroid. So uterine fibroid is not rare. While hysterectomied specimen of adenomyosis, this is red colored uterus, symmetrical. While in fibroids, it is asymmetrical enlargement and it is not rare. This is endometrial polyp, which is a mucosal growth, and the color Doppler sign is feeder vessel sign. How it is seen in color Doppler ultrasound, you can see here. This is the color Doppler appearance. This is feeder vessel sign. And this is hysteroscopy for diagnosis also, for treatment also, investigation of choice and treatment of choice. We see it by hysteroscope and we take it out. We remove it by hysteroscope. It is called hysteroscopic polypectomy. But for endocervical polyp, the cervical polyp is outside. We do not need this camera. We remove endocervical polyp just by a polypectomy hook. Your Vinesh sir, again, कितनी बार बोलूं कि सर्जरी को रसगुल्ला बनाते हैं. मैं भी, मेरे लिए भी RRR हो गया. तो दिस हैज ऑल्सो बिकम ए RRR दैट विनीश सर मेक्स सर्जरी अ रसगुल्ला. दिस इज ऑल्सो, मेरे को भी रीड रिपीट रिवाइज करते हुए रट चुका है ये सेंटेंस. फाइन, वी आर वेटिंग फॉर यू बेटा. पास होके आओ, फिर ऐसे ही मिलेंगे, सेलिब्रेट करेंगे. नेक्स्ट क्वेश्चन, छुपना पड़ेगा. ऑल ऑफ द फॉलोइंग स्टेटमेंट्स रिगार्डिंग PID. Sir, these so much in class. Sir, these topics you explained so much in class. Thank you, अहमद गौर. OBG तो सर अब कोई नीड में उठा के भी पूछ ले तो थैंक यू गजराज सिंह गुर्जर. थैंक यू गजराज सिंह गुर्जर. टीचर के लिए इससे अच्छा मोटिवेशन क्या होगा कि OBG तो सर अब कोई नींद में उठाकर भी पूछ ले. OBG चटवा दी सर, बेस्ट है, चटवा दी OBG. थैंक यू. आज मैं भी बढ़िया वाली चाय पीऊंगा अदरक की घर जाके. अगर तुम लोग खुश हो OBG से तो मैं भी खुश हो गया. क्वेश्चन नंबर 15. ऑल ऑफ द फॉलोइंग स्टेटमेंट्स रिगार्डिंग PID and their management are true except. Option A बेटा, beaded tubes on HSG, thin endometrium, caseating granulomas indicate genital TB. That's correct यार. ट्रीटमेंट, तुम इसका भी आंसर लिखने लगे क्या? नहीं, अभी नहीं लिखा. ट्रीटमेंट इज स्टैंडर्ड एंटीट्यूबरकुलर थेरेपी. राइट, करेक्ट स्टेटमेंट. HSG में बीडेड अपीयरेंस वी सी इन जेनाइटल ट्यूबरक्लोसिस. एशरमैन सिंड्रोम हो जाता है. थिन एंडोमेट्रियम. That is the feature of genital TB. बिल्कुल ठीक है. These are the keywords for diagnosis. Correct statement. Acute pelvic pain, fever, cervical motion tenderness, and mucopurulent discharge suggest PID. Treated with cefixime, doxycycline, metronidazole means kit number 6. बिल्कुल ठीक है. So cervical movement tenderness we see in two conditions, PID and ectopic pregnancy. In PID, UPT is negative, while in ectopic it is positive. So this is also a correct statement. Both chronic PID and genital TB can cause tubal infertility. Most common complication of chronic PID is infertility, and most common symptom of genital TB is infertility. Both of them are potential single liner questions for upcoming FMG exam. And what I have done, I have put these options in one option only. मैंने कहा बच्चों को 2.5 घंटे में पूरा पढ़ाएंगे. Can cause tubal infertility via adhesions and fibrosis. Management includes treating infection with assisted reproductive techniques if damage is irreversible. Best management for tubal block is in vitro fertilization, because fertilization happens in tube. If tube is blocked, we will do fertilization outside. ऐसे ही तो पढ़ा था हमने इस चीज को simplify करके. Option D. In confirmed genital TB, corticosteroids. Oh my God! अमित सर ने लिखवाया क्या? No. Are routinely added to ATP. So the correct statement is D. Let us see. The gold standard investigation for PID is laparoscopy, and most conclusive finding in PID is trickling of pus via femoral end of tube. Super duper important question. It is treated by kit number 6, doxycycline, metronidazole, cefixime, that I have put in one option collectively together here. तो एक ही ऑप्शन में मैंने इन सबको मर्ज कर दिया. These are HSG images. This is tobacco pouch. This is lead pipe. This is bilateral cornual block, and this is cotton wool appearance. Cotton wool appearance. ये सारी HSG images हो गई. Most common complication of PID is infertility. And see the questions carefully. If tube is completely blocked, then infertility. If tube is partially blocked, then ectopic. These two are again potential questions for upcoming 28 June exam. देखते हैं उस दिन. These pics can motivate us, बेटा. ये pics हमें फिर motivate करती हैं. Your Saha sir. Again, your Dhavam sir for ENT and Anupma ma'am for physiology. मजा आ जाता है बेटा. You can see that. See the emotions. पप्पा के चेहरे पे खुशी देखो बेटा. See the happiness. And his sister passed the exam in last to last session. So she is the sister. She passed the exam. She was also a student of MIST. Both of them were in online batch. She also passed from online batch in last to last session, and he was also in online live batch in last session. Next question. Question number 16. मैं फिर छुप जाता हूँ. Let me hide myself. All of the following statements regarding pathophysiology, diagnosis and management are true except prolonged obstructed labor can cause vesico-vaginal fistula. Steroids not given. Mayank, steroids not given. Yeah, right. Option A, prolonged obstructed labor can cause vesico-vaginal fistula. Definitive treatment is let's go repair after inflammation subside. Correct statement, because most common cause of vesico-vaginal fistula in developing countries like India is prolonged obstructed labor. So this is a correct statement. And treatment is done by let's go repair. This name is also very important, usually after inflammation subsides. Second option, methylene blue installation with dye leakage staining middle swab. So the keyword in the question is middle swab. And if dye leakage staining middle swab in vagina, it indicates vesico-vaginal fistula. So if middle swab turns blue and wet, diagnosis is vesico-vaginal fistula. Keyword smash, so correct statement. Leakage without dye suggests uretrovaginal. Another keyword for another question. So I have merged 3-4 questions in one option बेटा. आप ये देखो बेटा, मैंने 3-4 questions को एक ही option में merge किया है. So these 4 options are giving you 15 to 16 questions. This time I twisted the concept. I have put 3 or 4 questions in one option. Leakage without dye suggests uretrovaginal fistula requiring ureteric repair. Correct statement here. And the treatment of choice here is Boari flap repair. Uretrovaginal fistula, it is repaired with Boari flap repair. Vesicovaginal fistula causes bladder outlet obstruction. ये तो अमित सर ने पढ़ाया ही नहीं. वेसिकोवेजाइनल फिस्टुला कब से ब्लैडर आउटलेट ऑब्स्ट्रक्शन करने लगा? वेसिकोवेजाइनल फिस्टुला डेवलप्स एज द रिजल्ट ऑफ ऑब्स्ट्रक्टेड लोबर. तो ये तो बात जम नहीं रही, पूरा तो पढ़ लें. विद डिट्रूजर हाइपरट्रॉफी ड्यू टू हाई इंट्रावेसिकल प्रेशर. फर्स्ट लाइन ट्रीटमेंट नहीं 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 नहीं, यही तुम यार, मैं तो पढ़ता ही रह गया और तुम तो पढ़ के आगे भी चले गए. देयर इज यूरिनरी लीकेज ड्यू टू फिस्टुला, नॉट आउटलेट ऑब्स्ट्रक्शन. So how can option C be correct? Sir, in VVF, there is urinary leakage due to fistula. Very good, Deepak Kumar. Very good, Deepak Kumar. I am proud of you, Deepak. So the correct answer here is C because the question says accept. You are right. I respect your feelings. You are right. So answer is C, of course. वही अपन बात कर रहे हैं. Uterocervical prolapse results from laxity of pelvic support, the most common risk factor that we mentioned in the option. Management includes sling surgery, walled Mayo. Let me explain you these options, beta. The management for uterocervical prolapse, if she is nulliparous or congenital prolapse, it is abdominal sling operation. Most commonly done Virkut's abdominal sling operation, which is combination of Purandre and Shirodkar. If in the question it is mentioned, so this was the answer for uterocervical prolapse in nulliparous and congenital prolapse. If the question is management for uterocervical prolapse in multiparous lady, walled Mayo surgery, walled Mayo vaginal hysterectomy with pelvic floor repair. You can get third variant of the question, management of uterocervical prolapse in multiparous lady but who is unwilling for hysterectomy, जिसकी पड़ोसन ने आके समझा दिया, वो सारी बात क्लास में कर चुके हैं. The answer is Fothergill, which is also called Manchester, because Dr. Fothergill was working in Manchester Hospital. तो इस Fothergill को Manchester भी कहते हैं. If in the question it is mentioned that she is presenting with uterocervical prolapse, her age is around 60 to 65 years and there are some contraindications for surgery, leaf foot, colpoclepsia. What will be the answer, ring pessary, if there are absolute contraindications? For any temporary management of uterocervical prolapse, what is the treatment? Ring pessary in any young girl in whom there are some contraindications for surgery or who is unwilling. So we have covered the most common risk factor of prolapse, all the management of uterocervical prolapse in one option. तो टीचर ने दिमाग तो लगाया होगा ना, ऐसे ही तो नहीं ऑप्शन आ जा सिम सिम और ऑप्शन आ गया. हर काम में मेहनत लगती है, बातों से काम नहीं होते. This is methylene blue 3 swab test. That's the screening test. If topmost swab becomes wet but not blue, diagnosis is uretrovaginal fistula. If middle swab becomes wet and blue, diagnosis is vesicovaginal fistula. If only lowermost swab turns wet and blue, diagnosis is uretrovaginal fistula. This is a very important image question for upcoming exam. If they give this image, the defect is between bladder and vagina. So what is the diagnosis? Vesicovaginal fistula. Most common prolapse is cystocele. Most common fistula was vesicovaginal. What is cystocele? Prolapse of upper 2/3 of anterior wall of vagina along with urinary bladder cystocele. ये डायग्राम कहीं नहीं मिलेंगे पूरी दुनिया में, किसी किताब में. ये सब तुम्हारे टीचर ने पेड़ के नीचे बैठ के बनाए. Prolapse of upper 2/3 of anterior wall of vagina along with urinary bladder cystocele. Prolapse of lower 1/3 of anterior wall of vagina along with urethrocoele. Prolapse of upper 1/3 of posterior wall of vagina along with pouch of Douglas enterocoele, because pouch of Douglas contains loops of intestine. This is why intestine means entero. So this prolapse is called enterocoele. Prolapse of middle 1/3 of posterior wall of vagina along with rectum is called rectocoele. Isolated prolapse of lower 1/3 of posterior wall of vagina is called lex perineum. And what is the management for these prolapse? This is REFI. REFI means repair. Sling operation was called PEXI. Pexy means to fix or to solidify, but Refi means repair. So management for cystocele and urethrocoele is anterior colporrhaphy. We are doing repair in anterior compartment. Management for rectocele and lex perineum, posterior colpoperineorrhaphy. Best management for antrocele, MEC call caldoplasty. We are doing in persisting fashion. Other ones are Moskowitz and Halben repair. Fine. Again, these pics motivate you. Yeah. See the happiness. मैं अपने आप को छुपा लेता हूँ. See the happiness on parents' face. पप्पा के और मम्मी के चेहरे पे ये खुशी देखो बेटा. Next one, question number 17. All of the following statements, I will hide myself once again, beta. I apologize. पढ़ोगे कैसे? आदत भी तो डालनी है. वहां तो माउस भी नहीं चलेगा एकदम. कर्सर स्क्रॉल करते करते जान निकलने लगती है, बट हम प्रैक्टिस कर लेंगे. All of the following statements regarding infertility and treatment are correct except. फिर बेटा एक एक ऑप्शन में मैंने एक एक नदी को मर्ज कर दिया. एक एक ऑप्शन में एक एक कंसेप्ट को पूरा मर्ज किया है. दैट टू वेरी इंपॉर्टेंट फॉर अपकमिंग एग्जाम. Azoospermia may be obstructive, in which there is normal testicular size and normal FSH. Best differentiation between pretesticular, testicular and post-testicular cause of male infertility is by FSH, and FSH is normal in obstructive azoospermia, testis size is normal, so it looks correct. While in non-obstructive, it is impaired spermatogenesis, means it is a testicular cause where FSH is high. Correct statement. In fact, most common cause of male infertility is testicular, and most common cause of testicular idiopathic. So these two keywords are important for our exam. Overall, most common cause of male infertility is testicular, in which FSH will be high. The best differentiation between pretesticular, testicular and post-testicular is by serum FSH. Option A is correct. Option B, तुमने आंसर भी कर दिया, तुम मुझसे बहुत आगे चल दिए. Female infertility evaluation includes ovulation, tubal patency, uterine cavity, ovarian reserve, and pelvic pathology. Yes, treatment may include ovulation induction, surgery, IUI, IVF or ICSI. It is also correct, beta. Most common cause of female infertility is anovulation. The second most common is tubal block, then uterine cavity problem, ovarian reserve problem. Management is IUI, IVF depending on the cause. Correct statement. Oligoasthenoteratozoospermia involves low count, poor motility and abnormal morphology. Let me see. Oligospermia means low sperm count. Correct yaar. Asthenospermia means altered motility. Correct yaar. Teratozoospermia means altered morphology. Correct yaar. And we know most important parameter in seminogram is sperm morphology. But in IVF, sperm motility is most essential. I hope you are listening very carefully. Most important parameter in seminogram is morphology of sperm. But in IVF, this is sperm motility which is most important. Varicocele contributes via heat, we all know, and can be treated with varicocelectomy here. ये भी correct है. All the options are correct. So varicocele पे तो एक और question बनता है ना. Most common cause of male infertility is testicular and idiopathic. We do not know what is the reason of altered spermatogenesis. But if the question is most common reversible cause of male infertility, it is varicocele and it is correctable. So A, B and C are correct. We summarize the concepts here. Option D, aspermia, azoospermia, oligospermia, asthenospermia, teratozoospermia and necrozoospermia all include absent sperm production. No, they are different. So this is the correct answer. Few words about our food in upcoming exam. Better this turmeric which contains curcumin. It is a very good antioxidant. So you can just mix 1 teaspoon in a glass of water or milk. That is a very good antioxidant, improves our memory and immunity. So it will keep infections away and it will improve memory. All the colored fruits and vegetables, they are very good. They have good fair number of antioxidants. All colored fruits and vegetables, and of course, you will wash them thoroughly. You will wash them thoroughly. Coconut water is really very good, especially for those who are living in South India. It's a luxury. Ginger, again, a very good antioxidant. I love ginger tea. So green tea also. So these things you can just add on. Almonds, walnuts, you know. Mystians को almond walnuts तो पूरे ही पता है. Again, let me hide myself so that you can just feel the emotions. See the happiness. And see the happiness on father's face. पप्पा के चेहरे पे भी खुशी देख लो बेटा. See the happiness on father's face. Your Anupma ma'am, your physiology faculty, see the happiness on father's face. I still remember this Bitia. She's from Manipur. She brought this shawl, and I'm sharing just one thing. Whatever I asked her, Beta, we are talking about how was everything. Sab acha tha, sir. Sab acha tha, sir. I still remember as if I'm talking to my daughter only. Sab bahut acha tha, sir. Sab bahut acha tha, sir. Such a nice girl. And Akshay sir, your orthopedic sir, awesome orthopedics faculty and awesome orthopedic surgeon. See the happiness. देखो बेटा, see the happiness on parents' face. पापा के चेहरे पे खुशी, मम्मी के चेहरे पे खुशी. Again, your Akshay sir, your Deepa ma'am, your awesome PSM faculty, Vineet sir, your awesome surgery sir. Next question. Question number 18. All of the following statements integrating menstrual physiology. Let me hide myself. All of the following statements integrating menstrual physiology, bleeding terminology, pathophysiology and treatment are true except normal cycle is 24 to 38 days with 2 to 8 days bleeding. Cycle after 38 days is infrequent and before 24 days is frequent. कितने MCQ समा गए इस सागर में. So normal cycle and correct statement. All the keywords are correct. And every keyword is a potential question for upcoming exam. So option A is correct. Option B, oligomenorrhea or irregular heavy bleeding along with obesity, normal TSH, proliferative endometrial biopsy is due to anovulation with unopposed estrogen, means there is no progesterone to oppose the action of estrogen, and disorganized endometrial shading, correct statement. So if there is high estrogen, there is no progesterone. It is unopposed estrogen, means there is no progesterone, means there is no ovulation. So anovulatory bleeding, irregular bleeding, maybe amenorrhea for 2 months, 3 months, 4 months, then she will complain of heavy bleeding. It is more in obese lady because obese lady has more estrogen, because aromatization maximally occurs in adipose tissue, correct statement here. No thyroid disorder, it is due to high estrogen, and there is no ovulation, so there is no secretory endometrium, only proliferative endometrial appearance in biopsy. So multiple keywords in one option and this option is correct. Option C. इतना तो समझ गए होंगे यार कि तुम्हारे टीचर ने कुछ तो पेड़ के नीचे बैठ के किया है. Option C. Treatment of above condition is with progesterone, OCP, letrozole, clomiphene citrate or total abdominal hysterectomy depending on cause. Yes, beta. Because drug of choice to treat anovulation due to PCOS is letrozole. If PCOS word is not mentioned, drug of choice to treat any anovulation. If PCOS word is not there, it is clomiphene citrate. This is why drug of choice to treat unexplained infertility is also clomiphene citrate, because most common cause of infertility is anovulation, and if it is unexplained means you do not find a cause, we assume it is anovulation. So drug of choice to treat unexplained infertility is also clomiphene citrate. And if she is a lady who is complaining of endometrial hyperplasia, then we have to do hysterectomy depending on cause, if atypical cells are seen in endometrial hyperplasia. That is also a proliferative endometrium. ऑप्शन ए, बी एंड सी आर करेक्ट. बेटा मैंने तो पूरा टॉपिक रिवाइज कर दिया, तुम सबने आंसर डी, कुछ लोगों ने ए किया है. मोहित, आई थिंक व्हाई डिड यू आंसर ए? ए तो नहीं होगा, डी होगा बिल्कुल. तुम्हारे दिमाग में ए क्यों आया बेटा? मैंने कुछ गलत लिखा था ऑप्शन ए में, 24 to 38, 2 to 8, cycle after 38, before 24. नहीं मोहित, I hope you got it now. So option D is incorrect statement. This is incorrect. Again, Anupma ma'am, your physiology faculty. See the happiness on parents' face. Parents के चेहरे पर ये खुशी देखो बेटा. See the happiness. चलो, let's move. एक चीज दिखाता हूं बेटा. Tree hugging is therapeutic. Let me share with you very important thing. Tree hugging. When we hug the tree, and I am telling you a very simple trick. There are parks nearby. All of you have the approach, access to go to a park. If you feel low, if you feel nervous that you are not able to revise, sir, revise नहीं हो पा रहा, ऐसा लग रहा है कि याद नहीं आ रहा, we are feeling low, anxious and depressed, just go to the nearby park. Of course, that park should be neat and clean and hygienic, and go to the nearby tree and just do tree hugging. इस पेड़ को ऐसे पकड़ लो बेटा. Tree listens to you. It is a bioenergy बेटा. It is a wonderful bioenergy. That's how I spent my time बेटा. मेरा तो दिमाग ही पार्क में चलता है. मेरा वर्क जोन ही पार्क है. मेरे से किसी ऑफिस में बैठ के कोई काम ही नहीं हुआ आज तक जिंदगी में. मेरा दिमाग जैसे ही मैं पेड़ के नीचे बैठता हूँ, whenever I go to park, sit underneath a tree, my brain starts functioning. That's my work zone. So go for some tree hugging. Go for some tree hugging. क्रिस्प रिवीजन हो रही है टॉपिक्स की परिधि को कर. सर क्या ही क्वेश्चंस बनाए हैं. क्रिस्प रिवीजन हो रही है टॉपिक्स की. आर्ट ऑफ क्वेश्चन. Thank you Paridhi, thank you so much, thank you very much, thank you. I hope voice is clear. Let me just check. Someone said voice. Let me just reconfirm whether voice is clear or not. I hope it should be clear. Am I audible properly? Am I audible? Pranam sir, this is Ayusha. Thank you Ayusha. I remember Ayusha. I still remember your Jagannath ji picture. You are from Odisha. When you came here, you brought that pic of जगन्नाथ जी. वॉइस ठीक है? वॉइस इज क्लियर? कोई दिक्कत तो नहीं आ रही? आई एम आस्किंग, वॉइस इज क्लियर एवरीवन? नहीं, किसी ने लिखा नहीं है. आई थिंक फाइन, वॉइस इज क्लियर. या सो ट्री हगिंग इज थेरापेटिक बेटा. माइंड माई वर्ड्स, दिस ट्री हगिंग इज थेरापेटिक. फाइन. नेक्स्ट क्वेश्चन. फिर से छुपना पड़ेगा मुझे. मैं दिक्कत करूंगा भी क्या? मेरे क्वेश्चन दिखने चाहिए. All of the following statements integrating. Clear. Thank you Deepak. Thank you everyone. Thank you Anushka. Thank you Chelsea. Thank you Gajraj. Fine. All of the following statements integrating leiomyoma type, pathophysiology, clinical presentation and treatment are true except option A. Intermenstrual bleeding, infertility, recurrent early pregnancy loss plus cavity distorting lesion may be submucosal fibroid. Correct statement yaar. Submucosal fibroid and endometrial polyp, these two cavity problems cause intermenstrual bleeding, which is also called irregular bleeding. Irregular cycle is different na. Irregular cycle is if cycle to cycle variation is more than 20 days. Intermenstrual bleeding is also called irregular bleeding, which is due to two reasons: cavity problem, submucous fibroid and endometrial polyp. We discussed conceptually in detail in our classes na. Treatment is hysteroscopic myomectomy, and we know beta, hysteroscopic myomectomy is done for which submucous fibroid? Only for type 0 and type 1, not for type 2. You will get a question. Hysteroscopic myomectomy may be done for which submucous? For type 1 and 2, not for 2, because 2 is less than 50% in endometrium. We discussed in detail now in classes conceptually. Second option. So option A is correct. Option B, intramural fibroids are within the myometrium. Okay ji, correct hai. And may cause heavy menstrual bleeding, while subserosal fibroids project outward and more often cause pressure symptoms such as urinary frequency years, anterior wall cervical fibroid, cervix के बाहर निकल रहा है, posterior wall cervical fibroid, constipation पीछे जा रहा है, and pressing rectum, pelvic pressure. Pressure will cause pain. Correct है यार? ये भी बिल्कुल correct है. And most common fibroid overall is intramural. Intramural is also called interstitial. Option C. C. All of you are answering, sir, C least common. Very good. Very good, Mayank. C is least common. Most common complication is hyaline degeneration, and least common complication is malignancy, leiomyosarcoma, and risk of malignancy is just 0.5%. Risk of malignancy is just 0.5%. Very good. Correct statement. Acute pain in pregnancy plus tender fibroid plus low grade fever heterogeneous USG is red degeneration of fibroid. Red degeneration of fibroid, very good, and it is due to venous thrombosis and aseptic infarction. Most common time of red degeneration of fibroid is second half of pregnancy, because pregnancy is a hypercoagulable condition. This is why most common time of red degeneration of fibroid is second half of pregnancy. And in this question, how will you differentially diagnose torsion of fibroid? If it is a torsion of fibroid, there won't be any fever. If fever word is mentioned, it goes in favor of red degeneration of fibroid. If all the keywords mentioned, fever is not mentioned, that goes in favor of torsion of fibroid. So the correct answer is C. It is the rarest complication of fibroid. It is not the most common complication of fibroid. Again, few picks just to motivate you all. These picks motivate me as well. Your Deepa ma'am, awesome PSM faculty. These picks motivate me too. मुझे भी motivate करती हैं ये picks. बेटा ये this sentence is also very close to my heart. Whenever we feel lonely, anxious or depressed, बस एक चीज याद रखना, गीता में भगवान कृष्ण ने एक बात बोली है. लॉर्ड कृष्णा सेड इन द गीता इन हिंदी, पहली लड़ाई ही जीतनी है अपने ही आप से. दूसरा कोई हमारा दुश्मन नहीं है. हमारा सबसे बड़ा दुश्मन हम खुद है. मुझसे याद नहीं हो रहा. आई एम नॉट एबल टू रिमेंबर. What will happen on the exam day? Will I be remembering everything? Will I have a recall on exam day? That's why Lord Krishna clearly said in Gita that पहली लड़ाई लड़नी है अपने ही आप से और पहली लड़ाई जीतनी है अपने ही आप से. कैसे जीतनी है? Just take a pledge. My tomorrow is better than my today. रात गई, बात गई, आज जो हुआ वो हुआ, कोई बात नहीं. मैं अपने कल को अपने आज से बेहतर बनाऊंगा. बस इतना सा सोच लो, जो हुआ आज हुआ, कल मेरा है. आई विल मेक माई टुमारो बेटर देन माई टुडे. आई विल डू बेटर वायरिंग ऑफ माई न्यूरॉन्स टुमारो, सो दे विल बी फायर्ड इन ए बेटर वे ऑन 28th जून. पहली लड़ाई जीतनी है अपने ही आप से. रात गई, बात गई, मेरा कल मेरे आज से बेहतर होगा. डू नॉट कंपेयर योर मार्क्स ऑफ मॉक टेस्ट. Just see how many silly mistakes you avoided in this test and take a pledge. I will try to commit less silly mistakes in next test. Rest leave on the God. जिसके साथ ये है बांसुरी वाला, उसको किसी के साथ की जरूरत नहीं. मेरी बात याद रखना. बस इसका दामन थाम लो, बांसुरी वाले का. सिर्फ इसका दामन थाम लो. बाकी सब मिथ्या है, झूठ है, स्यूडो है, मरीचिका है, मृगतृष्णा है, माइरेज है. पहली लड़ाई जीतनी है अपने ही आप से. नेक्स्ट क्वेश्चन. लेट मी हाइड माई सेल्फ. ऑल ऑफ द फॉलोइंग स्टेटमेंट्स इंटीग्रेटिंग पैथोफिजियोलॉजी, एम्ब्रियोलॉजी एंड ट्रीटमेंट आर ट्रू एक्सेप्ट. थैंक यू गजराज सिंह गुर्जर सर. हमारे साथ भी आप हो, हम भी नहीं हारेंगे. बेटा आप सबके साथ तो हम हैं, लेकिन हम सबके साथ वो बांसुरी वाला है. ऑल ऑफ द फॉलोइंग स्टेटमेंट्स इंटीग्रेटिंग पैथोफिजियोलॉजी, एम्ब्रियोलॉजी एंड ट्रीटमेंट आर ट्रू एक्सेप्ट. ऑप्शन ए 46XY फीमेल. ये क्वेश्चन कहीं नहीं मिलेंगे बेटा, ढूंढते रह जाओगे. ये तुम्हारे टीचर ने पेड़ के नीचे बैठ के बनाए हैं. 46XY फीमेल विद स्ट्रिक गोनाड्स, intact Müllerian structures, increased gonadotropins, absent secondary sexual characters, indicates Swyer syndrome. And what's the treatment of Swyer syndrome? Orchidectomy as soon as the condition is diagnosed. So orchidectomy is done early. We are not waiting till puberty. In testicular feminization syndrome treatment, we do orchidectomy after puberty because that testis is giving us androgen which are aromatized to estrone, and that estrogen gives secondary sexual character. So in management of testicular feminization syndrome, we do orchidectomy or gonadectomy. Testis is a gonad, so you can say orchidectomy or gonadectomy after puberty. Important keyword for management of Swyer syndrome, we do orchidectomy as soon as condition is diagnosed. Another tricky keyword difference beta. In management of Swyer syndrome, we give both estrogen and progesterone because uterus is present. While in management of androgen insensitivity syndrome, we give only estrogen because uterus is absent. So we are not scared of any endometrial hyperplasia. There is no uterus, so how can there be any endometrium? तो हम डरेंगे क्यों? Fine. Option A is correct. Uterus is present here. Option B. 46XY, again a male, गायनी पढ़ रहे हैं, लड़के की बात कर रहे हैं. 46XY with normal breast, okay जी, secondary sexual characters, they are normal in testicular feminization syndrome, absent in Swyer syndrome. Absent uterus, absent axillary pubic hair. Axillary pubic hairs, they are absent in testicular feminization syndrome. The diagnosis here with these keywords is complete androgen insensitivity syndrome, which is also called testicular feminization syndrome. And treatment is with post-pubertal gonadectomy. So we take out testis after puberty. And we give only estrogen because there is no uterus, because there is no uterus. तुमने आंसर भी दे दिया, मैं समझ गया. इतना अच्छा पढ़ाने का मतलब ये हुआ, चलो मेरे को भी पता था बेटा, द वे वी डिस्कस टॉप स्काइनी, मेरे को पता था ये होगा. 46XX फीमेल विद नॉर्मल ओवरीज एंड सेकंड. लेकिन एक बात बता दूं बेटा, जरा कैमरा ऑन करके पढ़ लिया, यहाँ खूब आंसर भी कर रहे हो, लेकिन तुम्हारे टीचर ने ओबीजी का सब्जेक्ट वाइज टेस्ट भी पेड़ के नीचे बैठ के ही बनाया है. So you are having subject wise test of OBG on 24th, and your teacher went to a park, sat underneath a tree and prepared 200 obs-gynae question for your upcoming obs-gynae subject wise test. You will get 200 OBG questions on 24th May OBG test. बात समझ रहे हो ना? तो बिल्कुल ये मत सोचना कि अमित सर चॉकलेट बांटने के लिए OBG टेस्ट बनाने पार्क में गए थे. नहीं, अमित सर कुछ करने गए थे पार्क में, वो दिखेगा 24 मई को. चलो, ऑप्शन सी, 46XX फीमेल with normal ovaries and secondary sexual characters but absent uterus, cervix, vagina. It is Mayer-Rokitansky-Kuster-Hauser syndrome. Treatment is with vaginoplasty and fertility is with IVF and surrogacy. We know very well, if Müllerian duct is absent, uterus is absent. So it is clearly mentioned absent uterus, cervix, vagina because they develop from Müllerian duct. It is MRKH syndrome. We know in type 1, only Müllerian duct is absent, while in MRKH type 2, along with absence of Müllerian duct, there is renal anomaly and skeletal anomaly. Most common anomaly associated with Müllerian is renal. This is why every time whenever there is Müllerian abnormality, we have to assess renal function. Assessment of renal function should be done. Whatever I am speaking in this session, अपार्ट फ्रॉम दीज ऑप्शंस, बेटा मैं इन ऑप्शंस के अलावा और भी बहुत कुछ बोल रहा हूं, और जो भी बोल रहा हूं अपने पूरे होश हवास बिना किसी नशे का सेवन किए बोल रहा हूं. मैं इस सेशन में कोई गल वही कीवर्ड्स यूज कर रहा हूं जो 28 जून को कंप्यूटर स्क्रीन पे दिखेंगे. वॉट एवर कीवर्ड्स आई एम यूजिंग इन दिस सेशन, अपार्ट फ्रॉम दीज लॉन्ग क्वेश्चंस एंड ऑप्शंस, all those keywords which are not written here, but I am speaking, you will just see those keywords on 28th June. So listen the session very, very carefully. I am hiding myself once again because these questions and options are more important than my face. Fine. Treatment is with vaginoplasty, and we know the best vaginoplasty is Vichetti vaginoplasty, and most common vaginoplasty is MEC Indo vaginoplasty. पूरा खेल ही रिवाइज हो गया. All three, swear, AIS, MRKH, result from androgen. Incorrect statement. So these are glimpses from our Obs-Gynae workbook, which you have written conceptually after carefully listening to the Obs-Gynae concepts in our Obs-Gynae classes. This is Müllerian agenesis, where Müllerian duct is absent, secondary sexual characters are normal, and the best vaginoplasty is VHT. Management of choice is vaginoplasty. We know that. Then it is about testicular feminization syndrome, which is also called androgen insensitivity syndrome, in which axillary and pubic hairs, they are absent and scanty, which is the key word mentioned there. And how do you manage it? In Swyer syndrome, orchidectomy is done immediately after puberty, and we are giving estrogen and progesterone both. While in testicular feminization syndrome, we are doing orchidectomy after puberty and we were giving only estrogen. So each and every keyword which I have put here in the question and option, this is from our Obs-Gynae workbook only. कमाल की बात एक है बेटा, कुछ भी ओबीजी वर्कबुक के बाहर नहीं है, लेकिन बस पेड़ के नीचे चला गया तो थोड़ा सा गेम चेंज कर दिया. चलो, लिव एज नेचुरल एज पॉसिबल बेटा, जितना नेचुरल जी सकते हो. इन अपकमिंग डेज फॉर 28 जून FMG एग्जाम, गो टू ए पार्क, डू सम ट्री हगिंग. किसी पेड़ को हक करो बेटा पार्क में जाके. देयर इज ए ample amount of bioenergy in the parks, and if possible try to walk barefoot. नंगे पैर चलने की भी कोशिश करो. We get negatively charged ions from the earth which neutralize our free radicals. In South India or in Maharashtra, if you have access to the sea beach, seashore is also a very good antioxidant. सागर किनारे, समुद्र का किनारा भी बहुत बड़ा एंटीऑक्सीडेंट्स है. All these green parks with good bioenergy, they are very good antioxidant. कुछ पैसा खर्च नहीं होता बेटा इसमें. They are very good source of energy. हमारा सारा डिप्रेशन रफू चक्कर हो जाएगा. एंड यहाँ जाके सिर्फ एक प्लेज लेना, my tomorrow is better than my today. My tomorrow is better than my today. चलो, next one. I'm hiding myself. Question number 21. Thank you Anishka. Thank you गजराज. हम तैयार हैं गुगली के लिए. ओह वेरी गुड गजराज, यू आर रेडी फॉर गुगली. कोई गुगली नहीं आएगी अब, ये सारे गुगले यहाँ आ गए. सारे गुगले यहाँ है. अब इसके बाद 28 जून को सिर्फ चॉकलेट मिलेगी एग्जाम वाले दिन कंप्यूटर स्क्रीन पे. चॉकलेट्स बट रही होंगी वहां, गुगली तो सारी आज ही आ गई. क्वेश्चन नंबर 21. All of the following statements about polyendocrine metabolic ovarian syndrome, PMOS, are true except we know the new name of PCOS, now it is PMOS. तो मैंने क्वेश्चन भी नए नाम से बनाया बेटा. I have framed the question with new name only. Now polycystic ovarian syndrome is called polyendocrine metabolic ovarian syndrome. So all are correct except, देखते हैं. Hyperinsulinemia, increased theca cell androgen production and decreased sex hormone binding globulin, which results in increased free androgen. तुमने फिर आंसर कर दिया. तुम भी, इसका मतलब मैं तुमको कुछ ज्यादा नन्ना मुन्ना समझ रहा हूं क्या? Good, very good beta. Salute to all of you for studying Obs-Gynae in such a conceptual way. Hyperinsulinemia, increased theca cell androgen production and decreased SHBG. I was not expecting that you will be that prepared because you were just done with all the subjects. The last test was PSM just day before yesterday. Hyperinsulinemia, increased theca cell androgen production and decreased SHBG. So there is increased free androgen. OCP is drug of choice to treat hirsutism. Let me put full stop here. Fine. Correct statement. Drug of choice to treat hirsutism due to PCOS, now PMOS, is OCP. And we know theca cell hypertrophy, theca cell hyperplasia occurs, which displaces all the follicles towards periphery, which results in necklace sign or string of pearl sign. Important image question for PCOS, now PMOS. Correct statement. Option B. Chronic anovulation, yes, means unopposed estrogen, yes. There is no progesterone because there is no ovulation, there is no corpus luteum, yes. So unopposed estrogen means it is proliferative endometrium, correct here. If there is no progesterone means ovulation did not occur. So how can you get secretory endometrium? It has to be proliferative, correct till here. So irregular shading, she will not have menses. After 2-3 months, when endometrium becomes heavy, it comes out in the form of bleach. That's too correct. ये भी सही है. Increased hyperplasia risk, बिल्कुल सही बात है. Only estrogen proliferates endometrium. Treated with cyclical continuous progesterones, because treatment of endometrial hyperplasia, if atypical cells are absent, is progesterone, because progesterone is anti-proliferative and progesterone downregulates estrogen receptors. So A is correct, B is correct. Increased LH-FSH, increased androgen production, follicular arrest. LH is high in PCO, FSH is low to normal. High androgens also arrest follicular growth and ovulation. Treatment is ovulation induction with letrozole. Drug of choice to treat anovulation due to PCOS is letrozole. And if PCOS word is not mentioned, drug of choice to treat anovulation overall is clomiphene citrate. That's why I am repeating once again. Drug of choice to treat unexplained infertility is clomiphene citrate. Unexplained means you do not find any cause. So we assume that most common cause of infertility is anovulation. Letrozole is aromatase inhibitor. How does it work? It increases FSH because it is an aromatase inhibitor. So androgens are not converted to estrogen. Option D. OCPs increase gonadotropin secretion to restore ovulation. Never. OCPs inhibit ovulation. That's why you were pretty sure just with one keyword, you were pretty sure. सर ऐसा लग रहा है इस बार पीएमओएस की फुल फॉर्म आई पर मैं पीओएमएस ज्यादा बोल गया क्या? आ भी सकती है क्योंकि बड़ा इंपॉर्टेंट अपडेट आया है ना बेटा, बिकॉज दिस डिजीज इज वेरी कॉमन, यू नो, एवरी थर्ड और फोर्थ गर्ल इज सफरिंग फ्रॉम दिस. तो पूछ सकते हैं, कोई बड़ी बात नहीं है. So this is the important image question for that PMOS. This is a string of pulse sign, because theca cell hyperplasia. So this is very important question. A string of pulse sign or necklace sign. Very, very important image question for our exam. These pics really motivate us. देखो कितना अच्छा लग रहा है ना बेटा बच्चों से मिलके. We are waiting for you all like this. आप सबका भी इसी तरीके से इंतजार है. We are waiting for all of you. वी फील मोटिवेटेड. हमारा भी डोपामिन सीरोटोनिन बढ़ जाता है इन पिक्स को देखने के बाद. दीज पिक्स रियली मोटिवेट अस एज वेल. लगता है कि हमने जो मेहनत की बच्चों के साथ वो रंग लाई. मेहनत तो बच्चों की ही थी, हमने तो थोड़ा सा अपनी तरफ से जो करते हैं वो कर दिया पेड़ के नीचे जाके. बट थोड़े अच्छे क्वेश्चन बनाने की कोशिश करते हैं, थोड़ा अच्छा क्लास लेने की कोशिश करते हैं, कंसेप्ट्स को बेटर एक्सप्लेन करने की कोशिश करते हैं. बिकॉज विनर्स डू नॉट डू डिफरेंट थिंग्स, दे डू थिंग्स डिफरेंटली. जीतने वाले कोई अलग काम नहीं करते, वो हर काम अलग तरीके से करते हैं और मिस्ट में हम यही करने की कोशिश करते हैं. चलो नेक्स्ट वन, फिर मुझे छुपना पड़ेगा. क्वेश्चन नंबर 22. अ 60-year-old woman presents with postmenopausal bleeding for 1 month. She attained menopause 10 years ago. Now she is complaining with postmenopausal bleeding. This was in INISET recall. You are right, Shubham. You are very correct. तो मैंने INISET नाम नहीं लिया. I didn't use the word INISET, नहीं तो बच्चों को लगेगा कि FMG का सेशन है. But this was in INISET. Just recent exam. यूजर सर ऑप्शन डी में ओसीपीज इंक्रीज गोनाडोट्रोपिन कल है, बट ओसीपीज इनहिबिट ओव्यूलेशन ना बेटा, ओसीपीज इनहिबिट ओव्यूलेशन. तो इनकरेक्ट स्टेटमेंट हो गया ना, इनकरेक्ट हो गया ना. यस शुभम. So postmenopausal bleeding for 1 month. She attained menopause 10 years ago. There is no history of HRT, hormone replacement therapy. General and pelvic examination are unremarkable. ठीक है जी. Transvaginal ultrasound shows an endometrial thickness of 7 mm with no focal mass. What is the most appropriate management? Very good बेटा, very good मेरे प्यारे प्यारे बच्चों, दिल खुश हो गया सेशन लेके, आज मजा आ गया. If a lady presents with irregular bleeding PV, what is the next step? Ultrasound, transvaginal ultrasound. And if in transvaginal ultrasound, endometrial thickness is 4 millimeter or more than 4 millimeter in postmenopausal lady, that's the cutoff thickness, it is called endometrial hyperplasia. And if endometrial thickness is more than 4 millimeter, what's the next step? Endometrial assessment. Very good. Super duper MCQ zone, important MCQ zone for upcoming exam. If a postmenopausal lady presents with irregular bleeding, what's the next step? Transvaginal ultrasound. And in transvaginal ultrasound, if the cutoff thickness is 4 mm or more than 4, because in postmenopausal lady, super duper important statement for our exam, the endometrial thickness should be less than 4 millimeter. If it is more than this, it is considered endometrial hyperplasia. And what is the next step? Endometrial assessment. So option C is correct. Very good. Endometrial biopsy. This is the glimpse from our OBS-Gynae workbook, which you have written with your own hands, and you were in the classes, you were listening the classes conceptually. So this is endometrial atrophy. Most common cause of postmenopausal bleeding is endometrial atrophy, thin endometrium. This is normal proliferative endometrium, trilaminar, triple layered. This is normal secretory endometrium, hyperechoic. If endometrial thickness is 4 millimeter or more than 4 millimeter and it is generalized thickening, this is called diffuse endometrial hyperplasia. And what is the next step? Endometrial aspiration cytology with Pipel or Vebra aspirator. They are expensive. So in India, we are doing this sampling with Carmen's cannula because that is cheaper. But if endometrial thickness is focal, at one particular point, we use the camera of uterus hysteroscope and we take the biopsy from here. So for focal thickening, what is done? Hysteroscopic biopsy. For diffuse endometrial hyperplasia, what is done? Endometrial aspiration cytology by Pipel or Vebra aspirator. We discussed in our OBS-Gynae classes like this only. याद आ रहा होगा, क्लासेस को पढ़ते हुए भी ऐसे ही हाथ से इशारे कर करके पढ़ा था, उसका इफेक्ट आज दिखाई दे रहा है. I can see the effect, the way we studied OBS-Gynae in our classes by these things only. ऐसे हाथ करके जब conceptually पढ़ रहे थे, I can see the response here. बच्चों की खुशी सामने. If less tranexamic acid, I couldn't get you. नरेंद्र दत्ता, आई कुडंट गेट यू. मेरी समझ नहीं आया बेटा. नरेंद्र दत्ता, थोड़ा सा ट्रेनेक्स थोड़ा सा एलेबोरेट करोगे? आई कुडंट अंडरस्टैंड. तुम टेमोक्सिफेन तो नहीं लिख रहे थे. यू आर राइटिंग टेमोक्सिफेन बिकॉज टेमोक्सिफेन कॉजेज एंडोमेट्रियल हाइपरप्लेजिया, because tamoxifen is estrogen antagonist on breast, so it is used to treat breast cancer, but it is estrogen agonist on endometrium, so it causes endometrial hyperplasia. बेटा दोबारा से लिखना एक बार, क्या पूछ रहे थे. चलो बेटा, एक चीज और बहुत अच्छी. These pics are very close to my heart, very close to my heart. बेटा एक कभी भी दिल में ख्याल आए ना कि घर से मस्जिद है बहुत दूर या घर से मंदिर है बहुत दूर, सिर्फ इतनी सी बात बोलना, घर से मंदिर है बहुत दूर, घर से मस्जिद है बहुत दूर, घर से गुरुद्वारा है बहुत दूर, घर से चर्च है बहुत दूर. चलो किसी बंदर को केला खिलाया जाए, चलो किसी बंदर को तरबूज खिलाया जाए. कौन जाए मंदिर यार, कौन जाए मस्जिद, कौन जाए चर्च, कौन जाए गुरुद्वारा, कौन जाए चार धाम. मैं कहीं जाता नहीं यार, मैं कहीं नहीं जाता. जब भी दिल में ख्याल आए ना यार, मैं वहां नहीं गया, मैं वहां नहीं गया. ट्राई टू गिव सम बिस्किट्स, सम ब्रेड. कोई बिस्कुट छोटा सा, कोई एक ब्रेड ले लो बेटा. ट्राई टू फीड सम डॉग्स, बट टेक केयर, कोई कुत्ता काट ना जाए, थोड़ा सा ध्यान रखना. पुराना शेर था ना, उस शेर को मैंने मॉडिफाई किया. पुराना शेर क्या था? घर से मस्जिद है बहुत दूर, चलो किसी रोते हुए बच्चे को हंसाया जाए. घर से मस्जिद है बहुत दूर, चलो किसी रोते हुए बच्चे को हंसाया जाए. मेरी छोटी सी बात मान लेना बेटा. किसी मंकी को, किसी काऊ को, किसी भी नीडी को छोटी सी हेल्प कर देना. 1 रुपए की, 2 रुपए की, 5 रुपी, 10 रुपी. Almighty will bless you in examination hall. you will have a beautiful recall of a question which you will be struggling on that day. किसी क्वेश्चन के आंसर के लिए जब स्ट्रगल कर रहे होगे ना कि याद नहीं आ रहा, अचानक से मिरेकल होगा एंड यू विल हैव अ रिकॉल इन एग्जामिनेशन हॉल. कोई यूनिवर्सल सुप्रीम पावर तुमको हेल्प करने के लिए आ जाएगी. तुम छोटी सी हेल्प करना. हैव गुड इंटेंशन फॉर एवरीवन. लेट एवरी एफएमजी पास द एग्जाम. लेट एवरी एफएमजी स्टूडेंट पास द एग्जाम. जलने वाले जलते हैं, जलना उनका काम है. जला जला कर राख कर देंगे. ऐसी दोस्ती हो गई है बंदर से, गाड़ी के अंदर आके बैठ जाते हैं, कार के अंदर आके बैठ जाते हैं, बराबर की सीट पे बैठ जाते हैं और बिल्कुल जंगल के बंदर हैं बेटा. आसपास मैंने एक जगह ढूंढ रखी है जहाँ छोटा सा जंगल है, मैं वहां चले जाता हूँ. बिल्कुल लाइन अप हो जाते हैं, चारों तरफ बैठ जाते हैं. मजाल है कि कोई काटने की कोशिश भी करे, कोई नहीं करता. आराम से प्रॉपरली हाथ में केला लेते हैं. कोई किसी केले को मैं डालता नहीं हूं वहां पे, प्रॉपर एटिकेट्स के साथ. चल ठीक है ना बेटा. वेरी गुड. आई ऑल्सो फीड देम. वेरी गुड राहुल, वेरी गुड राहुल, वेरी गुड राहुल, वेरी गुड राहुल. What's the management? You are asking something, Abhijit. If endometrial hyperplasia, she is bleeding. We see the endometrial hyperplasia report. If atypical cells are absent, the treatment is progesterone, anti-proliferative. If atypical cells are absent, the treatment is progesterone. If age is less than 45 years, only uterus is removed, total abdominal hysterectomy. If age is 45 or more than 45, then we remove ovaries also along with uterus. Total abdominal hysterectomy along with bilateral salpingo-oophorectomy. Fine. Let's go through few more pics. Your Saha sir with recently passed students. Vineet sir. Chalo. Let's move to next question. फिर छुपना पड़ेगा. I'm hiding myself. Question number 23. Question number 23. There is monkey park near you, Rahul. That's good. Wonderful. Very nice. Question number 23. 30-year-old G2P1L1 woman was brought to the emergency department with severe lower abdominal pain, dizziness and bleeding per vaginum for the last 4 hours. She had a history of 8 weeks amenorrhea and had not yet undergone an antenatal checkup. Her relatives reported that she suddenly collapsed at home and became progressively drowsy during transport to the hospital. Means she is landing up in shock. On examination, patient is pale, cold, clammy, pulse rate 140, tachycardia, blood pressure is falling, hypotension, respiratory rate increasing, marked lower abdominal tenderness with guarding and rigidity. Neurons which are wired together are fired together. Saurabh Kumar, I am very happy. Ectopic pregnancy. You are right. You are right. You are right. Dikshit, you diagnosed ectopic pregnancy. Dikshit is the first one to diagnose that we are talking about ruptured ectopic pregnancy. That's why her blood pressure is falling. That's why her blood pressure is falling. Very good. Uterus slightly bulky. Fullness felt in the fornix, urine pregnancy test is positive. So she is pregnant, she is landing up in shock. This is a case of ruptured ectopic pregnancy. What is the most appropriate next step in management? Now, please answer better. Admit the patient to ICU for observation and monitoring. Suction and evacuation of the uterus. Very good ectopic pregnancy, ruptured ectopic. I am very happy बेटा, मजा आ गया, दिल खुश हो गया. Very good. लेप्रोस्कोपी किसने लिखा? लेप्रोस्कोपी. Who wrote लेप्रोस्कोपी? किसने लिखा बेटा? अभिजीत. अभिजीत लेप्रोटॉमी करेंगे, स्कोपी नहीं. देखो क्या लिखा है, लेप्रोटॉमी. स्कोपी तो तब करते जब वाइटल्स स्टेबल होते है ना. यहाँ तो ब्लड प्रेशर फॉल कर रहा है तो लेप्रोटॉमी करेंगे. Admit the patient to ICU for observation and monitoring. No way. Suction and evacuation of the uterus मतलब ही नहीं है. Pregnancy तो बाहर है uterus के. Resuscitation, she is in shock with laparotomy and we will do unilateral salpingectomy. Unilateral salpingectomy. सो दैट इज द बेस्ट आंसर, सी इज द बेस्ट आंसर। देखो बेटा एक छोटा सा पिक और देखते हैं। काउस भी हो ना घर के पास में, तो ट्राई टू गो एट दैट प्लेस बेटा, कोशिश करके अनकंडीशनली विदाउट थिंकिंग एनीथिंग, जस्ट टेक केयर ऑफ एनी स्ट्रीट डॉग्स की भाई कोई कुत्ता काटने वाला ना हो, या अमित सर के कहने से किसी ऐसे मंकी के पास मत चले जाना जो देखते ही तुम्हारे ऊपर झपट जाए। अमित सर की तो दोस्ती हो गई है इन बंदरों से, अमित सर के दोस्त यही हैं, यही अमित सर का हॉलीडेइंग है, पार्क वहीं उनका दिमाग चलता है, वहीं मेरा दिमाग चलता है, बंदर गाय बस यही अपना सर्किल है बेटा, बस यही। और इतने प्यारे प्यारे बच्चे हो प्यार करने वाले, इससे ज्यादा कुछ चाहिए ही नहीं जिंदगी में। चल ये पुरानी एक पिक थी तो मैंने कहा आज दिखाता हूं बच्चों को कि कभी तुम्हारे अमित सर भी ऐसे लगते थे। जाने कहां गए वो दिन, जाने कहां गए वो दिन। बिल्कुल कोई बात नहीं, लेकिन जाने कहां गए वो नहीं। अब तुम्हारा टीचर क्या प्लेज दे रहा है, माई टुमारो इज बेटर देन माई टुडे। अब इससे भी बेटर बन के दिखाएगा तुम्हारा टीचर। आई विल स्टार्ट रनिंग फॉर 5 किलोमीटर, जिम आई विल स्टार्टेड गोइंग टू जिम। इस अपने इसी वर्जन से बेटर वर्जन बन के दिखाएगा तुम्हारा टीचर। वक्त लगेगा थोड़ा सा, ठीक है ना, इट्स फॉर हेल्थ यू नो, अपने आप को हेल्थी रखना बहुत जरूरी है। चलो नेक्स्ट क्वेश्चन, क्वेश्चन नंबर 24। अभी छुपने की जरूरत नहीं है, नो नॉट नीडेड, छुपने की जरूरत नहीं। 29-year-old woman, 29-year-old woman with symptomatic uterine prolapse desires uterine preservation for future fertility. A fertility preserving sling cervicopexy is planned. Mesh the following procedures with their anchoring structure. So this is for treatment of uterine prolapse. These are the procedures: Shirodkar sling operation, Purandre sling operation, and Khanna. So these are the options we have put here. So this is how we will be matching. So Shirodkar sling operation, we know, we remembered and we discussed in our classes how to remember S Shirodkar, S sacral, S Shirodkar, S sacral. So we are attaching Marcelline tape at sacrum in Shirodkar. So C will match with 3. C will match with 1. Purandre abdominal sling operation, we know in Purandre we are attaching it with rectus sheath. So 2 will match with P. And in Khanna sling operation, we attach it with anterior superior iliac spine. Anterior superior iliac spine. So what would be the answer here? 1 is C, 1 is C, and 2 is, what is 2? B, and 3 is A. CBA, CBA. So what is the correct answer? This one. Simple. मैं अपने आप को छुपा लेता हूं so that you can feel the emotions. Sure. Let's move to the next question बेटा. These pics motivate me too. मैंने अभी एक बात बोली थी बेटा, अब दिखा देता हूं। ऐसी दोस्ती हो गई है, बंदर कार के अंदर भी आके बैठ जाते हैं आराम से। बहुत प्यारी दोस्ती है, अपना यही सर्किल है बेटा। चलो ठीक है, अपनी बंदरों से दोस्ती है, गाय से दोस्ती है, प्यारे प्यारे बच्चों से दोस्ती है, किसी बड़े आदमी से अपनी दोस्ती हो ही नहीं पाई आज तक। चलो क्यों नहीं हो पाई? क्योंकि ये जितने बच्चे सुन रहे हैं ये इतने बड़े आदमी बनने जा रहे हैं कि एक दिन फक्र से तुम्हारा टीचर कहेगा इनको मैंने पढ़ाया था। देयर आर ओनली 2 persons in this world who feel happy when you move ahead of them. They are your parents and teacher. इस दुनिया में 2 ही लोग हैं जो बहुत खुशी महसूस करते हैं जब आप उनसे आगे निकलते हो, एक आपके मम्मी पापा, दूसरा आपका टीचर। बहुत बड़े आदमी बनने जा रहे हो आप, फक्र से कहूंगा मैंने पढ़ाया था। चलो देखो कितने प्यार से तरबूज खाते हैं ये बंदा। चलो लास्ट क्वेश्चन ऑफ द डे, फिर छुपना पड़ेगा मुझे। लास्ट क्वेश्चन ऑफ द डे, a 24-year-old primary gravida, a 24-year-old primary gravida at 19 weeks gestation was brought to the obstetric emergency department with complaint of severe headache, blurring of vision, facial puffiness, and swelling of both feet for the past 10 days. She also complained of decreased fetal movements for 2 days. She was a known case of chronic hypertension and had poor antenatal follow-up. On examination, her pulse rate was 96 per minute, blood pressure 170 by 100 millimeter of mercury, bilateral pedal edema was present, and the uterus corresponded to 18-week size. Fetal heart sounds were absent on Doppler examination. She was presenting with 19 weeks and uterine height correspond to 18 weeks. Ultrasonography revealed intrauterine fetal demise with severe oligohydramnios. Okay, severe oligohydramnios and gross congenital anomaly involving the fetal brain. Investigations showed urine albumin 3 plus. Yeah, preeclampsia, you are right. You are right. Everyone is right. You are right. It is a case of eclampsia. अभी तो ऑप्शंस खोले ही नहीं है बेटा. अभी तो हमने ऑप्शंस खोले ही नहीं है. केस ऑफ प्रीएक्लेम्सिया लैंडिंग अप टू हेल्प सिंड्रोम, उसके अंदर ट्रांसफर हो रहा है, ट्रांजिट हो रहा है प्रीएक्लेम्सिया इनटू हेल्प सिंड्रोम. अभी तो क्वेश्चन ही नहीं आया. अभी तो अपन समरी पढ़ रहे हैं. थ्रोम्बोसाइटोपिनिया, it happens in preeclampsia, so I hope you are confirmed now. अब confirmation हो गया. Because of platelet aggregation, thrombocytopenia होता है. बड़े डिटेल में conceptually we understood everything in our classes. And elevated liver enzymes because of liver hypoxia, that too we understood very well in our classes. After counseling, the family consented for termination of pregnancy. Oh beta, preeclampsia का तो question ही नहीं है ये. That's why I want to tell you, पूरी कहानी कुक होगी, पूरी स्टोरी कुक होगी, but they will be the last lines of the question, which will change the game. Now, after question number 25, I am telling you that last lines should be read first. तो आप retrospective जाओगे. लेकिन इन चीज को मैंने आपसे पहले क्यों नहीं बोला? Let's learn to understand the story also. स्टोरी भी तो समझ लें, वो भी अपने आप में एक आर्ट है. लास्ट लाइन पढ़ के तो हमारा फोकस वहीं शिफ्ट हो जाएगा. स्टोरी पढ़ना भी क्विकली आना चाहिए. सो दोनों तरीके से क्वेश्चन सॉल्व करने की कोशिश करो. एग्जाम में तो लास्ट लाइन ही पढ़ना, लेकिन अभी बिफोर योर प्रिपरेशन दोनों तरीके से एक बार पूरी स्टोरी भी देख लिया करो. आफ्टर काउंसलिंग द फैमिली कंसेंटेड फॉर टर्मिनेशन ऑफ प्रेगनेंसी अकॉर्डिंग टू द एमटीपी एक्ट. व्हाट इज द मोस्ट अप्रोप्रिएट मैनेजमेंट? नाउ सी द ऑप्शन. व्हाट कम्स टू योर माइंड? सो दिस इज नॉट ए प्री-एक्लेम्सिया क्वेश्चन, दिस इज ए एमटीपी क्वेश्चन. अब देखने की बात यह कि ये क्वेश्चन तो प्री-एक्लेम्सिया का था ही नहीं. पूरा हेडेक, ब्लरिंग ऑफ विजन, ब्लड प्रेशर, एवरीथिंग, ओलिगोहाइड्रमनियोस, फीटल डिस्ट्रेस, फीटल डिमाइज, पूरी स्टोरी कुक कर दी. बट व्हाट एग्जामिनर इज आस्किंग, भाई एमटीपी के लिए तुमको किसका परमिशन चाहिए? हेल्प. वो तो हो गया, क्वेश्चन तो वो है ही नहीं. क्वेश्चन इज अबाउट एमटीपी. प्रेगनेंसी कैन नॉट बी टर्मिनेटेड बियॉन्ड 12 विदाउट कोर्ट परमिशन. ये तो रॉन्ग स्टेटमेंट है. MTP may be done up to 24 weeks. Medical termination can be performed. Somebody writing B, somebody writing C. Let us see. Medical termination can be performed after opinion of one registered medical practitioner. No. This is 19 weeks gestation. Up to 12 weeks opinion of one doctor is enough. And in recent update, up to 20 weeks opinion of one doctor is enough. Opinion of one doctor, and between 20 to 24 weeks, opinion of how many doctors required? Opinion of 2 doctors. So this is before 20 weeks. So opinion of how many doctors would be required? Just 1. MTP can be performed after opinion of 1 registered practitioner. So correct answer is B. Correct answer is B. Up to 20 weeks, opinion of 1 doctor is required, and 20 to 24 weeks, opinion of 2 doctors required. Fine. Few other picks to motivate you all. Let us conclude the session. These are few scanners of MIST. This is MIST Instagram, MIST YouTube, and MIST Telegram. We are running a MIST NeuroWire series on MIST Instagram story as well, and on MIST Next Telegram group, where you get daily questions at MIST Next Telegram group for all the non-MISTians as well. And on MIST Instagram also, we are running a MIST NeuroWire series on stories only. And you get a fair number of questions at MIST Telegram. And on Miss YouTube channel. We are running a 25 most important question series right now. There are various other academic videos available at Miss FMG Next YouTube channel. Again, a pic with Dr. Juhi Sompura. That girl made us proud. Chalo ji. So let's call it a day. Thank you for patient listening. Thank you very much. Wishing you all the very best for upcoming 28 June FMG exam. Whatever I spoke in this session, beta, मैंने जो भी इस सेशन में बोला है, apart from the long questions and options, each and every word where I move from one topic to other is super duper important. So listen to this video very very carefully. बहुत कुछ ऐसा भी बोला है जो लिखा हुआ नहीं है, तो बहुत ध्यान से सुनना. All the very best बेटा. जिंदगी की सारी खुशियां मिले आपको. Let every FMG pass the exam. जलने वाले जलते हैं, जलना उनका काम है. जला जला कर राख कर देंगे. FMG हमारा नाम.